Assalamu alaikum, everyone. My name is Ismail Abdullah. I'm a fifth year medical student, and inshallah, today we will be having a quick review on the OSPE content for HNS and radiology. Uh, so far, my impression on HNS is that it's a very easy exam, inshallah. Uh, it's very straightforward, not tricky. Uh, Basically, you know, if you know it, you know it. You know what I mean? Uh, Regarding the OSPE, it's going to be anatomy heavy, very much so. But inshallah, we're going to cover all the important and relevant aspects to it. And same goes for radiology. So, inshallah, towards the end of this, we will cover clinical anatomy, common pathologies, and neuroradiology. And if you see it, you should know it. If you don't know it, then good luck having an educational guess towards it. So, let's start off with the skull. So, Bismillah. Now, what you really need to know about the skull is that skull is divided into two parts, the neurocranium and the viscerocranium. So the neurocranium basically is the skull base and the calvarium, right? And then the viscerocranium is the bones of the face. We have 8 cranial bones that you need to know, 14 facial bones as well. And of course, there are certain holes in your skull that act as passage vessels that acts as a passage for vessels and nerves. All right. Now, basically, we're inshallah towards the end of this session, you will be able to name all of these different bones. We're gonna go through them systematically. Uh, However, I put this picture here today just so that you can appreciate the interior and the lateral view of the skull. So as you can see, this is your frontal bone, and then you'll here have, you know, your sphenoid bone, you're gonna have your temporal bone, you're gonna have your parietal bone as well. And see here, an area where all these bones, meet is called uh the the petrion. All right. So here, this is the area where they all meet. A fracture to this area may lead to an epidural hematoma. All right. Why? Because just beneath it runs the middle meningeal artery. All right. It's very important that you know this. A very common MCQ, SEQ, and OSPE question. All right. Usually a scenario of a patient who had a road traffic accident and they fractured, you'll see that they fractured their, petrous bone or like their pterion right here. Uh, Epidural hematoma, middle meningeal artery. All right. But second thing that you guys need to appreciate when it comes to the skull is the sutures. So we have the coronal suture that runs coronally. Then you'll have your sagittal suture right here. And you need to know that the area where these two sutures meet is called the bregma. And then at the end here, you have your lambdoid suture. And when it meets with the sagittal suture, it's known as the lambda. All right. You can be asked to label which of the following is, the coronal suture, sagittal, or the lambdoid. Very important that you guys know this. And yeah. Now, coming to the foramina in your cranial in the cranium, all right? It's very important that you know them. Very high yield, and you are expected to be able to identify it and name what passes through it. Okay. So here we have our frontal bone. All right. So this is interior, this is a posterior, and this is the frontal bone right here. This is the ethmoid bone. Ethmoid bone, you have the crista galli, you have the cribriform plate, and then you have your sphenoid bone. All right. Sphenoid bone that looks like it has wings. You have the lesser wing, you have the greater wing, and then we have here our foramen rotundum. All right, foramen rotundum, what passes through it? the maxillary nerve, which is branch of the trigeminal. So it's the second branch of the trigeminal. Then you have the foramen ovale. Foramen ovale, what passes through it, you'll have the mandibular nerve. And then you'll have foramen spinosum. Foramen, what passes through foramen spinosum? So that's gonna, I think that's gonna be your middle meningeal artery. Okay. Then you'll have the cribriform plate. Through the cribriform plate, you're gonna have the olfactory nerve passing through. So something important, if it gets damaged, you get to have something we call anosmia, which is basically the ability to lose your smell. And then through the optic canal, which is right here, if you can appreciate it. All right, the optic canal, what passes through it is the optic nerve. Okay, and then you have the internal acoustic meatus, which is right here. All right, the facial nerve passes through, and the vestibular cochlear nerve. طيب. And then you have the jugular foramen. Jugular foramen, you have cranial nerve 9, 10, and 11 passes through it. And the hypoglossal canal right here, you have the hypoglossal nerve passing through. It's very important that you know all of these, very high yield, okay? And definitely expect an OSPE question from this slide. Now, let's talk about the front part of the skull, foramina. So the first foramen right here, number 1, here you have basically it's called the zygomaticofacial, all right, and you have the zygomaticofacial nerve passing through. Now, something about foramens, especially in the skull, whatever their name is, sometimes that's exactly what the content is. All right, so and inshallah, it's going to be very easy for you to remember. Then, secondly, right here, just above the orbital rim, right here, you have the supraorbital notch, and what passes through it, the supraorbital nerve and the vessels. And then you have the third one right here. So this is infraorbital. So if this is supraorbital, this is going to be infraorbital, and you're going to have the orbital nerve and vessels passing through as well. And then this one right here. So this is this is like the mental tubercle right here. So this is going to be the mental foramen, and what's going to pass through the mental nerve and the vessels. Now, something that's pretty clinically relevant here is that the supraorbital notch could be a trigger point for trigeminal neuralgia, which basically is an irritation to the first division of the trigeminal nerve. All right. Okay, skull fractures. Now, I've honestly not seen much about all these different kinds of fractures in your past OSPEs. However, we're going to go through them. The most high yield one, in my personal opinion, is going to be the basilar fracture. So let's start with the first one. The first one is called the diastatic fracture. So what does it mean? A diastatic fracture is a fracture that occurs along the natural lines of your sutures. All right. What can happen to them? They can either widen or separate. And this is very, very common in infants and children. All right. So it's going to be along your sutures. The second one is what we call a depressed fracture. And as you can see, it's a fracture where a segment of the skull bone is going to be broken and it's going to go inward, all right, towards the brain. Third is a linear fracture. So it's a straight line fracture within the cranial bone, but does not move. Unlike the depressed fracture where it just moves inside. This one does not move. It just stays where it is. All right. The last one is the basilar fracture. All right. So this is the basilar bone. This is like the area where it's at the base of the skull. Okay, given it's the basilar fracture. It involves the temporal, occipital, sphenoid, and ethmoid bones. And typically, it presents with something we call the battle sign and raccoon eyes. So the battle sign is basically going to be like a blood accumulation right here behind the ear. And raccoon's eyes is going to basically be periorbital ecchymosis around the eyes. All right, very high yield, very, very, very high yield. The basilar fracture is really high yield. All right. And then moving on, we have what we call the Lefort fractures or the midface fractures. Now, they're divided to three different categories. We have Lefort 1, we have Lefort 2, and we have Lefort 3. So Lefort 1 is going to be a low level right here, a low level horizontal fracture. All right. Now, what's going to happen in this fracture is that it's going to detach the heart palate and the upper teeth from the midface. So you're going to have what we call a floating palate. All right. Now, here, of course, is going to involve your lower maxilla, the anterolateral margins of the nasal fossa, the maxillary sinus as well, and the thyroid plates. All right. And everything else stays intact. Then moving on to the second one, which is the Lefort 2, and this is what we call a pyramidal fracture. See here, it's going to be mid-level, almost triangular-like fracture. And it separates what? It separates this pyramid kind of center fragment of the face from the surrounding zygomas and the cranial bones, and you're going to have what we call a floating maxilla. All right. Here, the inferior rim of the orbit is going to be broken. However, the zygoma is going to be intact, as you can see. In the third one, this one is a complete dissociation. So this is a high-level fracture, all right, transverse fracture, where the facial skeleton completely dissociates from the neurocranium. So the viscerocranium and the neurocranium completely dissociate from each other. Here, the zygomatic arch is definitely broken, all right? And since the skull base is involved, you're going to get symptoms like CSF rhinorrhea. You can also get dural tears, all right? So very, very important, very high yield. So let's have our first clinical scenario. So this is a 24-year-old male brought to the emergency department following a high-velocity motor vehicle collision. On initial examination, his Glasgow Coma scale was 14. He's hemodynamically stable, but complains of a severe headache and a persistent, salty-tasting clear fluid dripping from his nose, which increases when he leans forward. Physical examination reveals prominent bilateral periorbital ecchymosis without local soft tissue trauma. Upon formal neurological assessment of the cranial nerves, the patient is unable to identify the scent of coffee or soap presented to either nostril. What is your diagnosis? So, as you can see here, this is a patient, all right, who suffered, a high impact road traffic accident, and he's stable. However, he's having this severe headache and he's having this fluid dripping down his nose, right? And he's having basically bruises around his eyes and he cannot smell. So what could be your diagnosis? So this, I'm going to give you a minute. So what do you think? So this is going to be basilar skull fracture, all right, involving the anterior cranial fossa. And why would we say that so? Because there's three important symptoms that the patient, presented with. He's having CSF rhinorrhea, all right. So basically, there's CSF from the brain, all right, dripping down the nose. That's one. He lost his sense of smell, anosmia, and he also has raccoon eyes, which is the periorbital ecchymosis. And why does he have the periorbital ecchymosis? It's because the fracture that happened to the anterior cranial fossa, all right, is going to cause blood, bleeding, right? Some arteries going to rupture, and basically they're just going to follow gravity and they're going to accumulate around the orbit, all right? So now, skull, very easy. So again, the things that you really, really need to know really well, the foramens, the cranial, the different cranial fossa. You also need to know the basilar fracture very well, the Lefort fractures. These are very, very important. Tamam. Then we move to the scalp. Scalp is really, really easy. What you really need to know for a scalp, you need to know these layers exactly how they are. So we start off with the skin, moving on to connective tissue. Then we have this aponeurotic layer, and then you'll have the loose connective tissue and the pericranium. So scalp, very easy. Like you need to know this. This is a potential OSPE question, and it could also be an MCQ. So it's very, very important that you know this. Now, you need to know the basically the muscles that are in your scalp. So first of all, you'll have the frontalis, and then you'll have the occipitalis, and then they're joined by this aponeurosis right here. So they're supplied by the temporal nerve and the post-auricular nerve. All right, they function by elevating the eyebrows and wrinkles of the forehead. Okay, very, very important that you know the occipitofrontalis muscle. طيب. So again, it's two different bellies joined by this aponeurosis. So the frontalis part and the occipitalis. All right, you need to know their nerve. Very, very potential OSPE question. So in OSPE, you know, any muscle that you encounter, you have to know its name, the way it looks, and the nerve. Very important. طيب. Now, we're done with the scalp. So far, easy, right? Now, moving on to the face. Face is a bit heavy, so inshallah, yani, we'll make it easy. So now, looking at the face, mashallah, very muscular, all right? And there are certain muscles that you have to know. You have to know uh, their names, where they are, and their function and their nerve supply. So first of all, we start with the orbicularis oris. All right, so this is the orbicularis oris right here. All right. The orbicularis oris is a muscle that helps in closing your eyelids, and it is supplied by the temporal nerve. Then you have the zygomaticus major, all right, which is right here. All right. The zygomaticus major is a muscle that helps with the elevation of your upper lip, all right, and it's supplied by the zygomatic nerve. Then we have the buccinator, all right. The buccinator muscle is here in the cheeks, and it basically, supplied by the buccal nerve, and it presses the cheek against the molar teeth, and it also works with the tongue to keep food out of your oral vestibule. Okay. Then we have the orbicularis oris right here. All right, so it's a muscle around your mouth supplied by the buccal nerve, and it functions to close your mouth. Then we have the mentalis right here. All right, the mentalis, which is basically a muscle that helps in elevating your jaw, and it's supplied by the marginal mandibular nerve. And remember that we have a foramen right here. It's called the mental foramen that helps pass the mental nerve through. All right. And then you have the platysma. All right. Look at this muscle, platysma right here. So this helps in depressing your mandible, and it's supplied by the cervical nerve. So pretty straightforward, nothing really much to explain here. However, it's very important that you be able to identify them on the plastic models, and also on on images like this, and try to know their nerve supply and their action. Okay. Now, this is from your lab slides. And here it's very important that you be able to identify different arteries that, uh, you know, supply the face. Okay. So first of all, let's start with this artery right here in the back. So this is the occipital bone, hence occipital artery. Then this is where your temporal bone is, and here you're going to have your superficial temporal artery. Then right here, so this is your parotid, okay, and right here is the transverse facial artery, and then this is the superior labial artery, and this is the facial artery right here as well. Okay, very important that you know these. And then the veins. Usually the veins and the arteries accompany each other. Perfect example, like you have the superficial temporal vein right here. You have the transverse facial nerve, superior labial vein, facial vein, and the two ones that we haven't discussed in the artery part, you have the posterior auricular vein. So this is the auricle right here, and this is posterior to it, so posterior auricular vein, and this is your external jugular vein. External jugular vein is a very important high yield OSPE structure that you'll be asked to pinpoint. Okay, so it's very important that you know this right here. So now this is also from your slides. So basically, what you really want to know from this slide is that the fourth layer of the scalp, طيب, is dangerous. Why? Because if the infection happened to reach the fourth layer, all right, it can enter your cranium via the emissary veins. Okay, so that's something that you need to know. Very, I'd say this is probably more common to be tested in your MCQs. Something else that you want to know about the face, if you have an injury or an inflammation to your facial nerve, you could have something we call Bell's palsy. All right, so the patient will have drooping of the face, will not be able to smile properly. All right, as you can see right here. They could also have ptosis as well. And this one right here is the danger triangle of the face. Okay, why? Because this area right here is drained by your facial nerve and, sorry, facial vein, apologies. And the facial vein communicates with the cavernous sinus that is in the brain. So an infection, all right, an infection right there could, be carried all the way to the cavernous sinus and cause some sort of thrombosis. So it's very, very important that you know this. So we're done with the face. Very straightforward. Muscles, arteries, straightforward. Moving on to the nose. Nose is very important. The things that we're going to discuss in the nose, of course, is going to be the structure, the different parts of it, and whatever we study here, we can apply heavily in radiology. So I want you to focus with me. So first of all, we start with the external nose. All right. So the external nose, first of all, we have the apex of the nose, which is the tip right here. You'll have the wings around the nostrils, what we call the ala. And then you have the nostril opening right here. So this is going to be your nares, all right? And this is going to be your nasal septum right here, okay? And then a part of the nasal septum is going to be cartilaginous, and then the other part is going to be bony. So here you'll have the dorsum, which is going to be the bridge of your nose, and this is going to be the root where the nasal bones are, all right? The bony part. So superiorly, right here, you'll have the nasal bones, okay? You'll also have frontal processes of the maxilla. And inferiorly, we have the septal cartilage, as I mentioned, the alar cartilages as well, and the nares, okay? Very straightforward and clear. So now the nasal cavity is divided to, I'd like to divide it to three parts. You have the vestibule. So this is the nares, right? This is the opening. So right after the opening of the nose, you'll have the vestibule. And then you're going to have the respiratory region. And then you're going to have the olfactory region, which where your cribriform plate is and where your olfactory nerve runs. Okay. Now, in your respiratory region, you're going to have your different conchae. So you're going to have the superior conchae, the middle conchae, and the inferior conchae. And then you're going to also have something we call the choana. The choana here is basically where your nasal cavity communicates with the nasopharynx. Okay. Now, what are the certain openings that you have in nasal cavity, and what does it communicate with? So first of all, we have the right around the entrance in the skull. So you'll have the piriform foramen, okay, which is in the skull, and then it communicates into the nasal cavity. And then you will have the choanae that I just mentioned earlier, and it's going to lead to the nasopharynx from the nasal cavity. So you have the piriform foramen, which is just one foramen, all right, that's going to lead basically from the skull into the nasal cavity, all right? And then you have two openings, all right, right here. So this is going to be your choanae, all right, which will lead into the nasopharynx. So the choana, all right, which is right here, you need to know the borders of it. So superiorly, you're going to have the sphenoid bone. And inferiorly, you're going to have the hard palate, or like just the palatine bone. And then medially, you're going to have the vomer. And laterally, you're going to have the medial pterygoid plate of the sphenoid. Okay. Uh, Honestly, I haven't seen a question on this, the OSPE part, but it's good to know it. Yeah. Then you'll have the walls of the nasal cavity. Now, this is really high yield. This is very important. So, regarding the nasal cavity, all right, first of all, we will start with the medial wall. So, the medial wall right here, you're going to have the nasal septum. And then laterally, you're going to have the three conchae that we've mentioned, the meatus as well, and all the different bones that contribute to the nasal structure. And then superiorly, you're going to have the cribriform plate and the body of the spheroid bone. And then inferiorly, you're going to have the hard palate, okay? And which is basically the palatine processes of the maxilla and the horizontal plate of the palatine, or just the hard palate, okay? So again, medial wall, nasal septum, lateral wall, the conchaes and the meatuses that we've mentioned. Superiorly, or the roof, is going to be your cribriform plate and the body of the sphenoid bone, and the floor of the nasal cavity is going to be your hard palate. Okay, very, very high yield. Now, the nasal septum itself, right, is divided to the cartilaginous part and the bony part, right? So this is your interior, this is your posterior, and the interior part is majorly made of hyaline cartilage, as you can see. And then posteriorly, all right, you'll have the bony parts. Okay, so this part right here, superiorly, is the part that's made of the perpendicular plate of the ethmoid. And this one right here is the vomer. Okay. Uh, in radiology, we will discuss this further. You'll be able to see the vomer, you'll be able to see the perpendicular plate of the ethmoid as well, which we're going to discuss later, inshallah. Now, we have the lateral wall, all right, which is made up of the conchae and the meatuses. Now, when we say conchae, basically it's Latin for shell, and meatus is like a passage. Now, it's very important that we know the openings and what drains and what. طيب. So, first of all, we have the superior concha, middle concha, inferior concha as well. And right between the superior and the middle, we have the superior meatus. Right between the middle and the inferior, we have the middle meatus. And below the inferior concha, you'll have the inferior meatus. And above the superior concha, you're going to have the sphenoethmoidal recess. Okay? So, the sphenoid sinus drains through the sphenoethmoidal recess. And the posterior ethmoidal cells drain through the superior meatus. And the frontal sinus, maxillary sinus, and the interior and middle ethmoidal cells drain through the middle meatus, and the nasolacrimal duct will drain through the inferior meatus. It's very important that you know this because you could get asked in your SAQs, in your OSPE, and even in radiology questions and SAQs. All right. Now, the part where the superior and the middle concha are, it's part of the ethmoid bone, and the inferior concha is just a separate bone of the skull. Okay, it's very important to keep that in mind, but it's not as high yield as what drains in what. Okay. So again, sphenoid sinus in the sphenoethmoidal rhesus, posterior ethmoid in the superior meatus. Everything else genuinely in the middle meatus, and the inferior meatus, you're gonna have the nasolacrimal duct. Well, this is why when you cry, you'll have your tears running down your nose. It's because of it's coming from your eyes through the inferior meatus. Okay. Now, this is basically just me repeating myself again. Okay. Uh, so we move forward. Okay, the blood supply. Blood supply is very important to know, especially for your OSPE. So this is the nose. So I've made this drawing. I divided the nose. This is your nasal septum. All right. This is the upper part. This is the lower part of the nose. And right here, this red dot is your Kieselbach plexus. Okay. The lateral wall of your nose is supplied by the sphenopalatine artery. All right. And the upper part is supplied by the anterior and posterior ethmoidal arteries. Okay. And then the interior part of your nose is majorly supplied by the Kieselbach plexus. Now, what are the arteries that make the Kieselbach plexus? So they're called the SAGs. So you have the sphenopalatine, which is it's a branch of the maxillary artery. Then you have the anterior ethmoidal, which is branch of the ophthalmic artery. Then you have the greater palatine, which is a branch of the maxillary artery. And then you have the superior labial, which is branch of the facial artery. Okay, so let's see if we can find all of them here. So you have, this is the greater palatine right here. You have the sphenopalatine artery as well. This is the anterior ethmoidal artery. All right, and somewhere here, you're going to have the labial artery as well. These four arteries all come together to form your Kieselbach plexus. They basically supply the interior portion of the nose, including the medial wall as well. However, clinically speaking, when will this become relevant? When a patient presents with a lot of nosebleeds, or what we call them epistaxis, they're usually due to the Kieselbach plexus. All right. Like especially during the winter, especially in kids during the winter, they have very dry noses, and this is going to cause the arteries there to break. And when they break, they're going to have a lot of, epistaxis. Okay, so just again, the posterior part of your nose is going to be supplied by the interior and the posterior ethmoidal arteries. The lateral part is by the sphenopalatine, and the interior part is going to be by the Kieselbach plexus. Okay. All right. Now, we've done the blood supply. There's definitely nerve supply. Okay. So the special sensation, which is your smell, is going to be mediated by the olfactory nerve, which passes through the cribriform plate to the olfactory bulb. Okay. And then the general sensation is going to be supplied by trigeminal. Tamam. So we have two different areas. The first area is going to be your vestibule and the interior nasal mucosa. All right. So that's going to be by the ophthalmic. All right. And then the second one, which is basically the rest of your nasal cavity, is going to be through the maxillary division of the trigeminal nerve. Okay. Now these are the specific nerves that you need to know. So for the vestibule and the interior nasal mucosa, it's going to be the anterior ethmoidal nerve. But you need to know it's a branch of the ophthalmic. And the internal nasal branch of the infraorbital nerve and branches of the pterygopalatine ganglia, you need to know it all comes from the maxillary. However, if they just asked in general, what's the general sensation? What supplies the general sensation of the nose? It's going to be trigeminal nerve. And what supplies the smell? It's going to be your olfactory nerve. Okay? Like, this is important. It's very important, actually. This could be asked in your OSPE. This could be also asked in your MCQs. So, the mucus secretion in your nose. What increases your mucus secretion? What decreases your mucus secretion? And how? So parasympathetic is going to increase your mucus secretion, and sympathetic is going to decrease it. So let's see how. So first of all, we have the superior salivatory nucleus of the facial nerve, which is located in your pods. And then it's gonna, from there, you're gonna have the great petrosal nerve joining the deep petrosal nerve, and they will become the nerve to thyroid canal or the Vidian nerve. And then this Vidian nerve is gonna go all the way to your pterygopalatine ganglion, which is located in the pterygopalatine fossa, all right, where they're gonna synapse here, and then they're gonna go to the nasal mucosa and increase mucus secretion by vasodilation. طيب. So the great petrosal nerve joining the deep petrosal, becoming the nerve to thyroid canal. It goes to the pterygopalatine ganglion. They synapse there, and then basically provide parasympathetic innervation to the nose, causing vasodilation and increasing mucus production. Sympathetically, to provide the sympathetic innervation, you'll have the nerves from the intermediate lateral nucleus in the T1. So that's the lateral horn of the spinal cord. All right, there you're gonna have the sympathetic trunk, and then the nerves are going to synapse in the superior cervical ganglion. All right, they're gonna synapse there. Then through the deep petrosal nerve, they will go pass through the pterygopalatine ganglion. They do not synapse, they just pass through. All right, and then they go to the nasal mucosa, cause vasoconstriction. All right, and decrease your mucus secretion. Okay, so something clinically relevant here in Horner syndrome, you lose sympathetic activity. So you're going to have, you're going to lose basically the sympathetic innervation to the nose. So you can have, runny nose, part of your Horner syndrome. All right, you're going to have like a lot of mucus secretion, a lot of vasodilation in the nose, just because there's nothing that could oppose it. Okay. This is very important as well. So the lymphatic drainage of your nasal vestibule, which is right after the opening of the nose, is going to be through the submandibular lymph nodes, and everything else is going to be through the deep cervical lymph nodes. Okay. Like, this slide is really critically important because it shows how the nasal cavity is connected to all paranasal sinuses. And of course, this is also very important, which shows you the different pathways of infection and how it could reach, for example, the brain. All right. And it's also radiologically very important. So right now we're going to learn the basics, and then we're going to apply it later on in radiology. So first of all, the frontal sinus. All right. The frontal sinus, which is in your forehead right here. All right. It's in the frontal bone, drains through the middle meatus, if you remember. Okay, it's connected to your nasal cavity. So if you've had, for example, an infection in your nose, it could go to the frontal sinus. It could have frontitis, for example. All right, same goes with your ethmoidal sinuses, which is found within your ethmoidal bone. And we have the interior in the middle part draining in the middle meatus, and we have the posterior part draining in the superior meatus. Then we have the maxillary sinus, which is by far the largest sinus in your body. All right, it drains through the middle meatus, and it's present at birth. Two sinuses present at birth: middle, ethmoidal. Okay, it's very important that you know that, because sometimes they would trick you and ask you, what is present and what is not present during birth. Okay, and then you have the sphenoidal sinus, which is found within the body of the sphenoid, drains to the sphenoethmoidal recess. All right. Now, these sinuses, what they do, they reduce the weight of the skull. They help within voice resonance, and they warm and humidify inspired air. Okay, like so let's take a look. This is very beautiful. This model, which is present in the lab. So look at this. This is your superior concha. This is your middle concha. This is your inferior concha, and these are just the meatus right below them, right? This is your sphenoidal sinus within the sphenoid bone. This is your ethmoidal bone. This is your forehead, right? This is your frontal sinus, all right? This is the palatine bone, which floors your nasal cavity, all right? This is the vomer. This is the perpendicular plate of the ethmoid, and this is the septal cartilage part of your nasal septum, all right? It's very beautiful. You have to know these, and by knowing these structures, you could easily answer all border kind of questions, right? Okay. So this is another slide. So this is your superior concha, this is your middle concha, inferior concha, this is the septum, nasal septum right here. These are your ethmoidal sinuses. This is the maxillary sinus right here. It's very large, you can tell. And this is basically the roof of your nose, which is formed by the nasal, frontal, sphenoid, and ethmoidal bones. And this is the floor, which is formed by the heart palate. Okay. And this is another picture that you can also go through. But something that I'd like to highlight here is the opening of your sphenoethmoidal recess, which is right above the superior concha. Okay, so if you can see the concha right here, all three conchas, and this above it is the sphenoethmoidal recess. Okay, and if you can also notice the tubule opening into the nasopharynx right here. All right, this is the opening into the nasopharynx from the nose into the nasopharynx. So, what is this encircled area called, and what are the arteries that contribute to it? So this is the ethmoidal, this is the Kieselbach area. And the arteries that contribute to it, we have the sphenopalatine, anterior ethmoidal, greater palatine, and the superior labial as well. All right? Like the parotid region. Parotid is very, very important. It's has a lot of structures, a lot of borders that you need to know. So, first of all, something that I'd like to cover before I dig deep into this. Facial nerve pierces through the parotid, but does not supply it. All right. However, if we get to have inflammation of the parotid, or if we get to have tumors within the parotid, all right, whatever through the parotid, all right, the parotid is surrounded by this deep cervical fascia, which is basically so strong that if anything that enlarges within it, all right, is going to stay within it. Cool. So I'm going to go out. So this is going to compress your facial nerve, all right, which can lead to, facial nerve palsy, all right. So this is something that's very commonly asked within the parotid umbrella. Anyways, let's talk about the borders of the parotid. Very important. So this is your parotid right here. طيب. Superiorly speaking, all right, this is going to be your zygomatic arch. Okay, this is the superior border of the zygomatic arch. And then inferiorly speaking, this is going to be the somewhere right here, inferiorly, that's going to be basically the inferior border of the mandible. And then posteriorly speaking, right here, it's going to be the external ear and the sternocleidomastoid. And anteriorly, it's going to be the masseter muscle. Okay. Now, if you can notice right here, there's something like a duct. This is what we call the parotid duct. And if stones get to develop in it, it's called sialolithiasis. And you can actually feel it on the face. All right. Like if there are stones in it, like you could press and feel, like a stone-like structure. Okay. So very easy. Superiorly, zygomatic arch. Inferiorly, you're going to have the mandible. Then anteriorly, masseter. Posteriorly, sternocleidomastoid, and the external ear. Now, I know this slide is a bit wordy. It's very important that you know the parasympathetic and the sympathetic uh, innervations that happen to the parotid. So parasympathetic will decrease your salivation. Actually, no, it's the opposite. I'm so sorry. This is going to be sympathetic. This is going to be parasympathetic. Uh, no, actually, sorry. This is parasympathetic. This is sympathetic. However, this will increase salivation. This will decrease salivation. So here, you're going to have the inferior salivatory nucleus, which is going to be in your medulla. All right. So this is going to be the preganglionic cell body. All right. It's going to go all the way to the otic ganglion, which I'm going to show you in a bit. And then from there, all right, you get to have the auriculotemporal nerve that basically supplies the parasympathetic innervation. All right. You need to know that it all happens through the lesser petrosal nerve, as like in the preganglionic pathway. Okay. For the sympathetic, all right, it's gonna be through again the anterior mediolateral cell column in the spinal cord is gonna go through the superior cervical ganglion, all right, and basically it's gonna reach through the external carotid arteries and its branches, like the plexus will run along them. Okay. So what's the really most important part of this slide is that you know the postganglionic cell bodies. So this is going to be the otic ganglion, this is going to be the superior cervical ganglion, all right? And here the preganglionic pathway is going to be through the lesser petrosal nerve, okay? It's very high yield, all right? So what supplies the sensation to the parotid is going to be two arteries, the greater auricular nerve and the auriculotemporal nerve. Okay, again, the facial nerve passes but does not supply the parotid. And the lymphatic drainage is going to be through the pre-auricular lymph node that drain into the deep cervical nodes, just like the nasal cavity. And the venous drainage is going to be through the retromandibular artery, which basically connects the internal jugular and the external jugular. And again, this is a mistake. This is supposed to be increased salivation, and this will be decreased salivation. Okay. So when the carotid meets the parotid, okay, so you have the common carotid artery, which bifurcates at the level C3, C4, in the internal carotid artery and the external carotid artery. The main reason that I'm covering this slide is that I want to show you all the branches of the external carotid artery, and basically there are going to be two branches that terminate within the parotid, okay? So the anterior branches of the external carotid artery are going to be the superior thyroid, the lingual, and the facial. Tamam? Those are going to be the interior ones. And then posterior branches are going to be your occipital and the post-auricular ones. Okay, right here. This is the occipital, and somewhere here it's going to be the post-auricular. And then the medial ones are going to be your ascending pharyngeal arteries. And two branches that terminate within the parotid is going to be the maxillary artery and the the superficial temporal artery. Okay, very important that you know these. They might ask you, what are the two branches that would terminate in the parotid? So it's going to be the maxillary and the superficial temporal artery. Okay, so for the facial nerve branches at the stylomastoid foramen and within the parotid into 5 different branches. So we start off with the temporal branch, zygomatic branches. You have also the buccal branches. Okay, so how would you memorize this? This is a very nice mnemonic, to Zanzibar by motor car. So you'll have temporal, zygomatic, buccal, and then along the mandible, you're going to have marginal mandibular branches, and then you're going to have cervical branches along your platysma. Okay. So it's very important that you know these and you know what each supplies. Okay. And this is basically just a flashback that you see all the vessels that supplies the face. Okay. So which of the following, A, B, C, or D, relays parasympathetic fibers for the parotid gland. And what's the nerve that carries the preganglionic, all right? Focus on the word preganglionic, parasympathetic fibers to this ganglia. So which of the following, A, B, C, or D, carries the parasympathetic fibers to the parotid? So it's going to be A. And what is it called? It's going to be called the otic ganglion. And again, the preganglionic one is going to be the lesser petrosal nerve. Postganglionic one is going to be the auricular temporal nerve. Okay, so it's very important. Like, so we're done with the face. We're done with the face. Moving on now to the ear. So for the ear, basically you have the external ear, we have the middle ear, and we have the inner ear. Both external and middle ear are filled with air. The only part that's filled with fluid is the inner ear. We're going to talk about the structures that are found within the external ear. Then we're going to talk about the tympanic cavity. And then we're going to talk about the structures that make your inner ear as well. Okay. Like, so this is the external ear right here. I don't think you guys are expected to know any of these, honestly. However, you need to know that this part is called the concha, and you need to know that this is the external auditory meatus. All right. I'm not sure that you need to know all these labelings, particularly. I haven't even came across a single OSPE question that asks to know all these labelings. However, the most important ones are the concha and the external auditory meatus. Okay. So this is the external ear. As you can notice, all right, the outer 1/3 part of your ear is made of cartilage, all right? And the inner 2/3 part of the inner ear is bony, and it's within the temporal bone. طيب. And this is your ear canal right here. Okay, so this is within the temporal bone right here. So this is the inner 2/3, this is the outer 1/3. طيب, all the way from the concha to the tympanic membrane makes your external ear. تمام? Then, after the tympanic membrane, this part right here is the middle ear, or what we call the tympanic cavity. And then this part from the semicircular canal, all the way from the oval window, all right, to the cochlea, this is your inner ear. So let's look at the tympanic membrane. The tympanic membrane, I think you have to be able to identify it. This is a normal looking tympanic membrane. This is pars flaccida. This is pars tensa. Okay. Tumors are usually more likely located in the pars flaccida. This is going to be the short process of your malleus. Okay. This is the minibrium of the malleus. It's very important that you know this. You'll see why in a minute. And this is the cone of light, which is a triangular looking light structure on the tympanic membrane. And in the middle, this is called the umbo. Okay. Now, if this light happens to not be there when you're looking at the tympanic membrane, this can indicate that the patient could be having a middle ear effusion. Okay. So this is the only clinical relevance out of the cone of light. Okay. Right. Let's talk about the arterial supply of the external ear. So we have the posterior auricular artery, which comes from the external carotid artery, supplies the posterior auricle. You have the superficial temporal artery, which also comes from the external carotid artery, supplies the interior auricle. Now, where does this branch of the external carotid artery terminate at? Parotid. Okay. And then you have the deep auricular artery, which comes from the maxillary artery, supplies the external auditory meatus and the outer surface of the tympanic membrane. Okay. Very important that you know these as well. Now, this is the nerve supply of the external ear. So here you'll have the the auriculotemporal nerve supplying part of the interior it's going to supply the anterior part of the external auditory meatus. It's also going to supply your outer ear, okay? And this is going to be this part is going to be supplied by the greater auricular nerve, and here the concha is going to be supplied mainly by the facial and the vagus nerve, okay? And the vagus nerve is going to supply the posterior part of the external auditory meatus. So the interior is going to be supplied, the interior part of the external auditory meatus is going to be supplied by the auriculotemporal nerve, and the posterior part is going to be supplied by the vagus nerve, okay? And this is basically from behind as well. This is going to be the greater auricular nerve supplying it, and this is going to be supplied by the lesser occipital nerve. Uh, Honestly, I haven't seen much questions on the supplies of the nerve, the supplies of the external ear. But yeah, it's good to know it. Like, this is really important. Like, if I want to leave everything about the ear and remember one thing, it's probably going to be this slide, which is the middle ear or the tympanic cavity. Very commonly asked concept when it comes to the ear. So this is your tympanic cavity, okay? Just to refresh ourselves, where does it start and where does it end? So it starts after the tympanic membrane and it ends right at the oval window. صح? So that's going to be the lateral wall and this is going to be the medial wall, right? Makes complete sense. And then we have the roof. So the roof of the tympanic cavity is going to be the tegmental wall, okay? And that's basically going to separate it from the middle cranial fossa, which is going to lie right above it. And then the floor is what we call the jugular wall, all right? It's going to separate it from the internal jugular vein, okay? Anteriorly to the tympanic cavity, that's going to be the carotid wall. And that's also going to be where the eustachian tube is going to also be. And then posteriorly is going to be the mastoid wall. Okay, so interiorly carotid wall, then mastoid, tympanic membrane, oval window, and then you have the tegmental wall, which separates it from the interior cranial fossa, sorry, the middle cranial fossa, and then the floor is going to be the jugular wall, which separates it from the internal jugular vein. Very important. But what are the contents of the tympanic cavity? So if you look here, okay, you have the malleus, incus, and stapes. These are the three bony structures, or what we refer to as ear ossicles. Okay, the malleus is attached to the tympanic membrane. Hence, the short process of the malleus and the manubrium of the malleus seen on the tympanic membrane. Okay. Yep. And then we have two muscles that are found within the tympanic cavity. We have the tensor tympani and we have the stapedius muscle. Okay. And then we have two nerves that run also in the tympanic cavity. You have the chorda tympani and you have the tympanic plexus. Okay. Now it's very important that you know the chorda tympani will carry taste. Innervation will also carry parasympathetics to your submandibular and sublingual gland. Okay. And the stapes right here, the stapes, okay, is going to connect the lenticular process of the incus with the oval window. Okay. So this is another diagram that will help you just look at the malleus of the incus, stapes, all the way to the oval window. And this is going to be your tensor tympani, which is supplied by the third division of the trigeminal nerve. And what it functions is that it pulls the malleus medially. All right. This is going to make the tympanic membrane more tense, yet it's going to dampen the vibration, protecting the ear. Stapedius, which is supplied by the facial nerve, all right, this is the muscle right here, as you can see, it will pull the stapes posteriorly, stiffening your ocular chain, all right, and it's basically what we call the acoustic reflex to protect our ears from loud sounds. So it will basically decrease its you know the vibrations and the passing of the vibrations to the inner ear. طيب? So this will basically protect your ear. And this is what we call the acoustic reflex. Very important that you know it. Okay. طيب. Now, the middle ear has interior and posterior communication. The interior communication is going to be through the eustachian tube that connects your ear to the nasopharynx. Why? So that it can equalize the pressure between the middle ear and your atmosphere. Okay. Now, the thing about this is that usually when you have, you know, like certain sinusitis, or if you have strep throat, okay, and if it's left untreated, sometimes it could develop otitis media. Why? It's because the middle ear and the nasopharynx are connected via the eustachian tube. Okay, it's very important that you know this. And why children usually have higher incidence of having otitis media is because it's the eustachian tube is going to be shorter and wider in children. Hence, they're going to be more prone to otitis media. Okay. And then these are the muscles around the eustachian tube. So you have your tensor tympani. Look at it. It's a beautiful long muscle. This is going to be the tensor palatini muscle. And this is going to be the levator palatini muscle. And this is going to be the salpingopharyngeus muscle. Now, both tensors, the tensor tympani and tensor palatini, are supplied by the third division of the trigeminal nerve. And then the other two are going to be supplied by the vagus nerve. Okay. What else is supplied by the vagus nerve in the ear? That's going to be the posterior external auditory meatus. Right. Now, the posterior communication in the middle ear is going to be basically the middle ear is going to be connected posteriorly to the mastoid air cells, okay, via this passageway called the adductus to mastoid antrum. So all the way it connects it to the mastoid air cells, okay. This is why if you get to develop otitis media, you can also develop mastitis if the otitis media is left untreated, okay. So the arterial supply of the middle ear comes from three arteries. You have the anterior tympanic artery, which comes from the maxillary. You have the stylomastoid artery, which comes from the posterior auricular artery, which makes sense because the stylomastoid is right there behind your ear. And you have the petrosal branch, which comes from the middle meningeal artery. Okay. Just a quick flashback all the way to skull. If you hit the Pitrian area in your skull, you get to develop epidural hematoma due to middle meningeal artery rupture. Okay. Now, the inner ear. The inner ear is divided. So why do we call it labyrinth? Labyrinth is, I think it's Latin for maze. Okay, because it's literally like a maze. And we have two structures. We have the bony maze and we have the membranous maze. The bony part contains the perilymph, which is similar to CSF. The membranous part contains the endolymph, all right, which is similar to your intracellular fluid. And then within the membranous part, you're going to have your vestibule, which is basically your utricles and saccule, and you're going to have your semicircular canal and your cochlea. Now, you need to know that the utricle will help in detecting linear acceleration, and the saccule is also going to help detecting linear acceleration. And then in the semicircular canal, we have anterior, posterior, and lateral. Okay, and they help detecting rotational acceleration. And within the cochlea, you'll have the organ of Corti, which basically detect sounds. Okay, so this is the inner ear right here. So all the way from the oval window, and then you have the vestibular system, which basically helps with the balance, with the vestibule, the utricle and the saccule, and here you have the uh, the semicircular canals, and then the cochlea. Okay, so if you can appreciate, this is your organ of Corti right here. Okay, this is the cochlear duct as well. This is your cochlear nerve all the way. All right, so very, very easy, very straightforward. So again, this is the outer ear, this is your inner ear, and this is the middle ear, sorry, and this is your inner ear. Okay, but the inner ear is supplied by the vestibular cochlear nerve. Okay, now we have two divisions. We have the vestibular division and we have the cochlear division. The vestibular division is going to supply your utricle, your saccule, your semicircular canal. This will help within the balance, right? The utricle and the saccule helps in linear acceleration. Semicircular ducts will help within the rotational acceleration. And you have the cochlear division, which supplies the organ of Corti, all right, which detects sounds and help with hearing, all right? And then both divisions are going to travel all the way to the brainstem, okay? So again, vestibular cochlear nerve is what supplies the inner ear. Like, very important that you know this. Now, what supplies the arterial vasculature to the inner ear? That's going to be the labyrinthine artery. Oh, also, I forgot to mention something really important. This is uh, this is going to be through the internal acoustic meatus. Okay. Yeah. Okay. So here we have the labyrinthine artery. طيب. And then the labyrinthine artery is also known as the internal auditory artery, which supplies the inner ear, and it comes from ICA. So if you remember from, neuro, all right, ICA is a branch of the basilar artery. Okay, and labyrinthine artery is really a terminal artery, doesn't have any collateral circulation, uh, which means that if a sudden occlusion that gets to happen to your labyrinthine artery, you're going to get sensory neural hearing loss. Okay, but this was an OSPE question that bothered me, honestly. It says, which of the following images shows the right way to collect a swab for otitis media? What do you think? That's going to be C. We call it the tympanocentesis. Okay. But now we go to the fossas. If you guys want to maybe take a break for like 5 minutes and then resume. All right, and we're back. Okay, so moving on to the forces, or what I call them, the scary forces. They're actually pretty easy. They're not that scary. It's just that they're a lot, and sometimes, it gets a bit overwhelming. However, inshallah, we're gonna cover them all today, starting off with the Pterygopalatine fossa. We've heard the Pterygopalatine terminology before, right? In the Pterygopalatine ganglia, which is something that we're going to cover here as well. So this is part of your skull, basically zoomed into. And here, right here, you see this small cone-shaped structure. This is your Pterygopalatine fossa. Okay. It's very deep in the face, and it's like a crossroad of major nerves, arteries, and ganglia. And this is where basically they meet and they pass signals all the way to the face and the skull. طيب. You can see it's very highly vascularized area, has a lot of very important structures, right? Uh, so it's very important that you know the boundaries. This is one of the objectives in your OSPE. So this is your pterygopalatine fossa. Interior to it is going to be your posterior surface of the maxilla. All right, so it's just gonna be just right below the maxilla, and then the pterygoid fossa sits on the pterygoid process of the sphenoid, right? And then you're gonna have sorry, this is gonna be the posterior wall, so it's gonna have its back to it. However, it's gonna be sitting on a palatine bone, all right? So it is gonna be the inferior part, and and then the superior wall, which or the roof of the pterygopalatine fossa is going to be the greater wing of the sphenoid. So in front of it, right here, is going to be your maxilla, the posterior surface of the maxilla, and then posteriorly, you're going to have the pterygoid process of the sphenoid sitting. So this fossa is going to sit on your palatine bone, low key, all right, the pyramidal process of the palatine bone, and it's going to be roofed with the greater wing of the sphenoid. Okay. Medially, you're going to have the perpendicular plate of the palatine bone, and laterally, you're going to have the targomaxillary fissure, which is just an opening. Okay. Like, what are the contents of this cone-shaped fossa? First of all, we have the terminal parts of the maxillary artery that help in supplying the nose, palate, and orbit. You're going to have the maxillary nerve, which will enter the pterygopalatine fossa through the foramen rotundum, and you're going to have the pterygopalatine ganglion, all right, which basically provides the parasympathetic nerve cell bodies that belong to the facial nerve. And as we've mentioned, it helps within the nasal gland, lacrimal gland, and the palatal glands, which we already discussed, and we're going to brush over as well. So this is a refresher. This slide is really just a refresher to what we discussed earlier regarding the parasympathetic innervations of the facial nerve through the pterygopalatine ganglion. So right here, this is your pterygopalatine ganglion, right? This is just within your, within the pterygopalatine fossa. How does the parasympathetic innervation reach, the lacrimal, nasal, and the palatal glands? So remember, we've mentioned we have the great petrosal nerve that comes from the cranial nerve, the facial nerve, right? Joins the deep petrosal nerve. So this is the deep petrosal nerve right here. It joins the deep petrosal nerve, and then it becomes what we call nerve to pterygoid canal, or the Vidian nerve. It will synapse with the gland, and then it's going to basically pass through and provide, the parasympathetic innervation. Sympathetic part, the sympathetic input comes from the deep petrosal nerve, all right, from the internal carotid plexus. However, you need to remember that it passes through the ganglion, the pterygopalatine ganglion, but it does not synapse there. Okay, it does not synapse there at all. The synapse in the superior cervical ganglion. Okay, and you'll also have sensory fibers from the second branch of the trigeminal nerve. Okay, it will also pass through, but they do not synapse. So it's very, very important that you know these. Okay. Uh, However, you need to know the branches of the pterygopalatine ganglion. So you have the nasopalatine nerve, greater palatine nerve, lesser palatine, posterior, superior, and inferior lateral nasal nerves, and the pharyngeal nerves. Okay, so they're all located in one certain area, right? They're all palatine. It just you want to know which part is naso, greater, lesser, and then the pharyngeal nerve. Okay, this is also part of your OSPE objectives. Now, for the lacrimal gland, this is a bit interesting. So again, same thing. We have the preganglionic nerves coming all the way from the facial nerve, synapses. Of course, it goes through the greater petrosal nerve. Then you'll have through the Vidian nerve, synapses in the pterygopalatine ganglion. And then something cool that it does is that it hitchhikes the zygomatic nerve. Okay. These postganglionic fibers are going to hitchhike the zygomatic nerve. They goes all the way to the lacrimal nerve and then supply the parasympathetic innervation to the lacrimal gland and then making you cry. Okay, I hope the exam does not make you cry. So this is how the lacrimal gland gets innervated parasympathetically. Okay, the only thing that's different here is that it hitchhikes the zygomatic nerve. Okay, like the pterygopalatine fossa is a connection hub. All right, and why do I say it's a connection hub? It's because it connects all different parts of your skull and the face, all right, all through this fossa. Okay, and this is very, very, very important when it comes to the radiology aspect we're going to discuss later on. So the pterygopalatine fossa, all right, communicates with the middle cranial fossa through your foramen rotundum. Okay, that's where you have the maxillary nerve. Tamam. It will also communicate with the orbit, with the eye, through the inferior orbital fissure. And then it's also going to communicate with the nasal cavity via the sphenopalatine foramen. And it will communicate with the infratemporal fossa via the pterygomaxillary fissure. And this makes the lateral wall, remember? And it's going to communicate with the external skull base via the pterygoid canal, which is right here. Okay. Like, and it's also going to communicate with the heart palate via the palatine canals. All right. And it's going to give off the branches their greater and lesser palatine nerves. It's very important that you know how it communicates with each different structure. Okay. And what openings it communicates through. Very high yield, extremely high yield. Okay. A nice way that I put it that you can remember, I'm a pretty nice palate person. So the eye goes for the infratemporal fossa. It's important that you know what it even communicates with. Okay, so it communicates with the infratemporal fossa through the pterygomaxillary fissure laterally. The anterior superior part of it is going to be the orbit. Okay, through the inferior orbital fissure. The P is for posterior superior, which is going to be your middle cranial fossa, nasal cavity, pterygoid canal, and the palatine canals. Okay, but the maxillary artery has a lot of branches actually, and it depends on the location. So we have three locations that we need to cover. We have the mandibular area, we have the pterygoid area within the infratemporal fossa, and we have the pterygopalatine area, which is within the pterygopalatine fossa. So this is a schematic of the maxillary artery, and here you'll see that these are the branches, all right, within the first part. okay, which is the mandibular area. So here you're gonna have accessory meningeal, middle meningeal, anterior tympanic, deep auricular, inferior alveolar, and then here you'll have second part, deep temporal, pterygoid artery, mesteric artery, buccal artery, and this is the third part as well. Okay, pharyngeal, artery to pterygoid canal, sphenopalatine, and infraorbital, greater palatine, and the posterior superior alveolar artery. You have to know the branches. They might ask you, uh, so for example, you have these three, right? What branches are located in the mandibular area? What branches are located in the pterygoid? What branches are located in the pterygopalatine? Sometimes they can also say infratemporal fossa, so you need to know that, you know, the pterygoid is within the infratemporal fossa. Okay. So it's very important that you know the branches and where they are. Okay. And then we have the pterygoid venous plexus. Okay. So basically, this is just a meshwork of veins that happen to lie around the pterygoid muscle in the infratemporal fossa. And basically, what happens is that the all these veins will drain into your maxillary vein right here. So see, this is the meshwork, right? They're gonna drain into the maxillary vein right here, and then they're gonna join the superficial temporal vein. Okay, so maxillary vein will cross path with the superficial temporal vein, making retromandibular vein, which is gonna connect the external jugular vein with the internal jugular vein. Okay. Now, why is it clinically important? Because it connects to the cavernous sinus via the emissary nerves. Oh my God, again, the emissary veins. So this is what we call remember the dangerous triangle of the face, right? So any facial or dental infection can spread intracranially through the emissary veins from the pterygoid venous plexus. Okay. It also connects with the inferior ophthalmic vein. So it connects the orbit to the plexus. So again, any infection could ascend there. And it also connects the facial vein, connects with the facial vein through the deep facial vein. All right. So these are basically the clinical relevance. Like they can ask about pathways. All right. That, for example, let's say, how did this infection reach there? Okay. Or how they can all just purely ask about anatomical connections. Like, for example, how is it connected to the orbit? How is the plexus connected to the orbit? Through the inferior ophthalmic vein. How is it connected to the facial vein? Through the deep facial vein. Okay. So that's all about the pterygopalatine. So we just really need to know that there are maxillary arteries within it. We have the maxillary nerve within it. We also have the pterygopalatine ganglia. Okay. Then we move into the infratemporal fossa. Okay. So this is your infratemporal fossa. It's really just irregular spacing that's below and medial to your zygomatic arch. Okay. And deep to the ramus of the mandible. So it's right here. It's very important that we cover the boundaries. So let me put myself here. Okay. So this is the superior, this is the floor, inferior, anterior, posterior. All right. And superiorly, all right, we have the infratemporal surface of the greater wing of the sphenoid, which is right here. This is the greater wing of the sphenoid. This makes the roof of the infratemporal fossa. Then you'll have anterior to it is going to be the posterior surface of the maxilla. And then posteriorly, you're going to have the tympanic plate, you're going to have the mastoid and the styloid processes of the temporal bone, all right? And then the floor is just going to be open. Nothing is going to limit it inferiorly. And it's medial. It's going to be medial to the lateral pterygoid plate, and it's going to be lateral to the ramus of the mandible. Okay, so again, anteriorly, you're gonna have the maxilla. Posteriorly, you're gonna have the tympanic plate, and you're gonna have the styloid and the mastoid processes of the temporal bone. And superiorly, you're gonna have the greater wing of the sphenoid. Inferiorly, it's gonna be open. Okay, it's gonna be medial to the lateral pterygoid plate and lateral to ramus of the mandible. Okay, so if you can appreciate it again right here. Okay, like so. This is the anterior wall. This is going to be, I'm stressing on it because this is really high yield. So this is going to be the anterior wall, right? This is going to be the posterior surface of the maxilla. All right, this is going to be the ramus of the mandible laterally. Medially, this is going to be the lateral pterygoid plate. Okay, and this is where it's going to be. See, inferiorly, nothing holds it. All right, it's just going to be there. And then posteriorly, you're going to have the tympanic plate, styloid processes, mastoid processes of the temporal bone. And then superiorly, it's going to be the greater wing of the sphenoid. Okay, beautiful, very clear, very easy. I hope this picture depicts exactly the borders of the infratemporal fossa. Okay. Now, what are the contents of this infratemporal fossa? First of all, if we go back a bit, the otic ganglion is located in the infratemporal fossa, right? That's number one. Number two, we have the mandibular nerve, inferior alveolar nerve, lingual nerve, buccal nerve, chordotympany nerve, all are within the infratemporal fossa. In my opinion, two nerves that are very high yield that you need to know, the mandibular nerve and the chordotympany nerve. Then you have the pterygoid venous plexus that we just mentioned earlier. And we have the maxillary artery, the first and the second part, right? And then the medial pterygoid muscle and the lateral pterygoid muscle, which makes sense, right? So these are the contents. You have to know them, okay? Now, the mandibular nerve. Mandibular nerve, which is connected to the infratemporal fossa through the foramen ovale, all right, has a lot of branches that we need to be aware of. So we have meningeal branches, all right, they could just re-enter the skull. We have the auriculotemporal branches, which are very important. We have the buccal nerve. We have the inferior alveolar nerve branches, and we also have the lingual nerve. And something about the mandibular nerve, it's probably the only part of the trigeminal that supplies both sensory and motor, all right? Because the lingual nerve is, gonna have the also taste and sensation to the interior two-thirds of the tongue. All right, the motor branches, all right, are the muscles to mastication. So it's gonna provide nerve to masseter, deep temporal nerve, medial pterygoid nerve, and lateral pterygoid nerve. Okay. Yeah, that's pretty much it. Okay. Now you might say, how does the mandibular nerve provide, the lingual nerve and, the function is taste and sensation? It's just that the chordotympany, all right, that comes from the facial nerve is going to join the lingual nerve in the infratemporal fossa. Hence, through the lingual nerve, all right, you'll get the taste and sensations of the interior two-thirds of the tongue. Okay. So that's pretty much it for the infratemporal fossa. Very easy, very straightforward. You need to know the boundaries, the content. That's it, pretty much. Temporal fossa. Temporal fossa, just put it here for the sake of completion. It's like a ball, honestly. All right. You need to know, of course, what makes the superior border. So the superior and the posterior border are made up of the temporal lines, as you can see. And then the inferior border is made up of the infratemporal crest. The interior border right here is made up of the frontal and the zygomatic bones, right? And the floor is made up of the pterion, which basically is a point where all these four bones meet up, right? The frontal, the temporal, and the greater wing of the sphenoid, right? So they all meet up right here. Tamam. And of course, this is clinically important because if it gets fractured, you're gonna get epidural hematoma. It's very high yield, like extremely high yield. You're definitely gonna get a question on it. Now, what sits here in this ball? Two things: temporalis muscle and temporal fascia. So it's called temporal fossa, and it has a muscle that's called the temporalis muscle, and it has fascia that's called the temporal fascia. All right. And major superior and posterior border are the temporal lines. Inferior border is the infratemporal crest. And anteriorly, what basically borders it is the frontal and the zygomatic bones. Very easy, very straightforward. I honestly don't think that you will get a question about the temporal fossa, but in case you do, here you go. Okay. Next we have is the TMG, which is the temporal mandibular joint. Okay, this is a very important joint and a very unique joint. Okay, because the only movement it allows is the gliding movement. Okay, so these are just anatomical landmarks. Here you have the zygomatic process of the temporal bone. Here you have the mandibular fossa, and here you have the articular tubercle, right here. Okay, so in the articular surfaces, we have superiorly, all right, the mandibular fossa and the articular fossa, okay, right here. And inferiorly, you're gonna have the head of the mandible. طيب. Now, if you look here at this cadaveric dissection, all right, this is going to be your TMJ, okay? And within your articular disc, it gets divided to an upper synovial cavity and a lower synovial cavity. Why so? The upper part is going to be responsible for gliding movement. It's going to be responsible for protrusion, for retraction. The lower part is going to be responsible for rotation, which basically mouth opening and mouth closing. Okay. Now, you also need to know the ligaments that support this important joint. So we have, first of all, we have the lateral ligament, which is right here. So this is the joint, and this is the ligament that's lateral to it. So this is the lateral ligament. And then you'll have the sphenomandibular ligament as well. You have the stylomandibular ligament as well. All right, so these are the three ligaments that support the TMJ. Now, if the lateral ligament gets to be ruptured, you can have posterior dislocation. If the sphenomandibular ligament is not working properly, then you could have, you know, just a lot of protrusion. Okay. If the stylomandibular ligament is not working, then you could have excessive protrusion. Okay. So you need to know the functions and how it protects, the TMJ. Okay. Muscles of mastication. Of course, we start off with the temporalis muscle. Okay. Temporalis muscle, it helps with the elevation and retraction and lateral deviation as well. The masseter muscle, it also helps with elevation and protrusion. The medial pterygoid helps with elevation and protrusion as well. And the lateral pterygoid helps with the depression, all right, of the mandible, all right? So it will basically open the mouth. Okay, so depression of the mandible, protrusion, and lateral deviation. Very important. All are supplied by the mandibular nerve. Okay, so it's very important that you know the actions. Okay, and the way that you locate them. Don't know why the figures are showing up, uh, but it's supposed to be a plastic model. I don't know. Yeah, okay, we can have one here. So before that, this is your masseter muscle, which basically is anterior to your parotid gland. All right. This is going to be your temporalis muscle right here. Okay. This is your buccinator muscle right here as well. So right here. Okay. If you look here, this is going to be your masseter muscle again. This is going to be your temporalis. right? This is going to be the zygomatic arch, all right? And right here, this is going to be the lateral pterygoid, okay? And this is going to be the buccinator muscle, okay? And these are just processes. This is the condylar processes, the process of the mandible. This is going to be the mandibular notch, and this is going to be the coronoid process of the mandible, okay? And this is the TMJ right here, okay? But now we're done with the fossas, moving on to the neck, okay? So in the neck, really it's divided to anterior and posterior part, and we have the interior triangle of the neck, okay? This is the interior triangle of the neck, and within the interior triangle of the neck, we have four different triangles that we need to cover, okay? So the first one is the submental triangle. The submental triangle, which is right here, it sits exactly in the midline, okay? And it has this digastric muscle, all right, both on each sides laterally, okay? And then it has the mylohyoid bone, which basically is inferior to the triangle. So it's the floor of the triangle, the submental triangle. And within this triangle, you'll have submental lymph nodes and anterior jugular veins. It's very important that you know that, okay? All right. So this is for the submental triangle. Moving on to the submandibular triangle. Okay, so this is the submandibular triangle right here. So if you look inferiorly, you have the anterior belly of the digastric muscle. And then if you look posteriorly, all right, posterior to the submandibular triangle, you're going to have the posterior belly of the digastric muscle. And not just that, you'll also have the stylohyoid muscle right there. Okay. And then superiorly, you're going to have the inferior border of the mandible, and the floor of the submandibular triangle is going to be the mylohyoid and the hypoglossal muscles. Okay. Now, what are the structures that are found in the submandibular triangle? Of course, you're going to have your submandibular gland. You're going to have the facial artery, facial vein. You're going to have the hypoglossal nerve, mylohyoid nerves and vessels, styloid processes, and its attached muscles as well. But really, really, the things that are high yield that I want you to remember: submandibular gland, facial artery and vein, hypoglossal nerve, submental artery. Very, very important. Okay. So again, let's repeat the borders because I feel like it's very, very important for you to know. Okay, so this is the submandibular triangle. Tamam. Superiorly, you have the inferior border of the mandible. The floor where it sits in is going to be the mylohyoid and the hypoglossal muscle. Hence, it has the hypoglossal nerve, right? And then inferiorly, you're going to have the anterior belly of the digastric muscle. And posteriorly, you're going to have the posterior belly of the digastric muscle, right? If you basically know the borders, you're going to be easily able to identify the contents, right, of the submandibular triangle. Then we have the carotid triangle. It's a very high yield. Actually, out of all the four triangles, this is maybe the most commonly asked triangle in OSPEs and SAQs. Sorry, MCQs. The carotid triangle. So right here, this is the carotid triangle. Okay, so posteriorly, this is going to be the sternocleidomastoid. Anterior-inferiorly, it's going to be the superior belly of the omohyoid right here. So this is anterior-inferiorly. And superiorly, it's going to be the posterior belly of the digastric and the stylohyoid muscle. All right, right here. So it's very important that you know this. Okay. But the content. So see, this small triangle has all of this. So if you think about it, the most things that it carries are genuinely things related to the carotid. Like you have the common carotid artery, so you have the internal and the external carotid arteries right there. You're going to have the carotid sinus, the carotid body, and of course, you're going to have the internal jugular vein, vagus nerve, hypoglossal nerve, spinal accessory nerve as well. All right, and the external carotid artery branches. Okay, usually the interior ones, yeah. So uh, basically, it's very important that you know this, but also it's like common sense for you to make a guess of what the contents of the carotid triangle is. Maybe the only part that's going to be just a bit confusing is the kind of nerves that's going to pass through the carotid triangle. So it's going to be 10, 11, and 12. Okay. Now, the last triangle is going to be your muscular triangle. Okay. The muscular triangle, the boundaries of the muscular triangle, first of all, if you see it right here, okay, this boundary medially, it's going to be the midline, the superior belly of the omohyoid, and then you'll have the anterior border of the sternocleidomastoid inferiorly. All right. What really sits here is going to be your infrahyoid muscle, your thyroid gland, your parathyroid glands, the larynx, the trachea, and the esophagus. Okay. So yeah, I hope it makes sense. Okay. So here, just put this picture so that you can look at the hyoid bone. All right. So this is the mandible. This is your hyoid bone. This is the larynx. Okay. Now, anything that's above the hyoid is called suprahyoid. Anything that's below the hyoid is called infrahyoid. Okay. So suprahyoid muscles, which sit above the hyoid bone, all right, helps in elevating the hyoid and the floor of the mouth, which will help in mouth opening and assist in swallowing. So there are four muscles: digastric, mylohyoid, stylohyoid, and geohyoid. All right. You need to know the innervations, of course. So digastric, the anterior belly is by the mylohyoid nerve, which comes from the mandibular division. You have the posterior belly, which comes from the facial nerve, mylohyoid from the mylohyoid nerve, stylohyoid from the facial nerve, and geohyoid is from C1 via the hypoglossal nerve. Okay, it's very important that you know this. So, yep. Infrahyoid, they help with depressing the hyoid and the larynx after swallowing. So, yep. So you have sternohyoid, and then you have the thyrohyoid, and then you have the omohyoid as well. All right, so if you look here, all right, so you have, see, two sternohyoid muscles, okay, one on each side. So it's going to be from C1, C3. The thyrohyoid is going to be from the hypoglossal nerve, and omohyoid is going to be C1, C3 as well. So, yep. How would I remember this? I'll just think that below the hyoid, I have the sternum, and basically they're inserted into the sternum. If you look, most of these muscles are inserted into the sternum. All right. And for the other muscle, which is the thyrohyoid, I'm just gonna think of it because basically the thyroid gland sits below the hyoid bone. Okay. Now moving into onto the posterior triangle of the neck. Very easy. All right. Very straightforward. The posterior triangle of the neck, it's basically gonna be behind the sternocleidomastoid. That's number one. طيب. So this is, and then you'll have the floor of your posterior triangle of the neck is going to be the prevertebral fascia covering the scalene and other muscles right here. And it's the roof, superior part, is going to be the investing layer of the deep cervical fascia. And inferiorly is going to be the middle third of the clavicle, just right here. And interiorly, it's going to be the sternocleidomastoid. Posteriorly, it's going to be your trapezius. Okay, so just to repeat, the boundaries of the posterior triangle of the neck. طيب. Superiorly, you have the investing layer of the deep cervical fascia. Inferiorly, you have the middle third of the clavicle. The floor, where it sits, is basically going to be the prevertebral fascia that covers the scalene muscle and other muscles in there. Anteriorly, you'll have the sternocleidomastoid, and posteriorly, you're going to have the trapezius. Now, what sits in my posterior triangle of the neck? First of all, you'll have the omohyoid, splenius capitis, levator scapulae, and the scalene muscles. The vessels, you're going to have external jugular vein, subclavian vein, and subclavian artery. And the nerves that pass through, you're going to have the accessory nerve, okay? Honestly, it supplies the trapezius, so I just think of it. This is how I remember it. You have the cervical plexus as well, and trunks of the brachial plexus, okay? Now, if you look at the posterior triangle of the neck, all right, it's divided by the inferior belly of the omohyoid. It's divided into subclavian triangle and occipital triangle. All right. So if you look at the occipital triangle, it takes up the major portion of the posterior triangle of the neck. So here is where you gonna have your accessory nerve, lesser occipital nerve, great auricular nerve, mainly the brachial plexus as well. All right. And within the supraclavicular triangle, which sits right here, by the way, they interchange the names. It could be called subclavian or it could be called supraclavicular. I like to call it subclavian. Why? Because it's going to make me easily remember the contents, which is going to be the subclavian artery, subclavian vein, and the external jugular vein. So anything that's nerve related to the posterior triangle of the neck is going to be within the occipital triangle, and anything that's related to vasculature, vessels, is going to be within the subclavian or the supraclavicular triangle. Okay, just 1 minute, please. I want to connect my MacBook to the. All right. Now, another thing that you need to know, which is part of your objectives, is the muscles of the floor from the back to the front. طيب? And this is the order of the muscles from the back all the way to the front. So we start off most inferiorly, you have the splenius capitis, all right? Then the levator scapulae, the posterior scalene, middle scalene, anterior scalene, and the semi-spinalis capitis, okay? It's part of your objectives. I've honestly never met a question that talks about this. So it's a bit low yield, I think, but I just put it here for the sake of completion. Okay. Now let's take a look. This is the omohyoid, all right? Very clear to see it. So this triangle right here is going to be the subclavian, and this right here is going to be the occipital. So any nerve that I see here, I can be able to pick up. Look at this nerve. This nerve is going all the way to the trapezius, so it's going to be the accessory nerve, all right? And then here, this is parts of the brachial plexus. This one right here is going to be my subclavian vein. This is going to be my subclavian artery, okay? It's very important that you know these. Okay. So, what's the name of this triangle and what are its contents? First of all, is it anterior or posterior? And why? It's going to be interior, right? Why? Because it's in front of the sternocleidomastoid. Easy, صح? Then, what is it called? So it's just right above the omohyoid, right? Below the digastric, the posterior belly of the digastric muscle. So this is going to be the carotid triangle. And the contents, everything related to the carotid. What are the nerves that pass through the carotid triangle? 10, 11, and 12. Okay. So yeah, common carotid artery, internal jugular vein, vagus nerve, hypoglossal nerve, and also the spinal accessory nerve. Okay, and now we reach our final part, which is the eye. So Before we dig into the boundaries of the orbit of the eye, I would love that you guys appreciate these high yield fissures and openings within the orbit. We have the optic canal, where the optic nerve passes through. We have the superior orbital fissure, and we have the inferior orbital fissure. Okay. So the orbit. It's very important that we know the boundaries of the orbit and we know what makes the medial wall. The medial wall is so high yield because even in the radiology lectures, they emphasize on the medial wall highly. Okay. The lateral wall, the roof, and the floor. So let's take a look at it. So first of all, the orbit. The orbit is a pyramid-shaped bony socket. Okay. You might not see that it's a pyramid like this, but if you look at it from the inside out, it is a pyramid-shaped bony socket. All right. The superior wall, what makes the superior wall of the orbit is the frontal bone, lesser wing of the sphenoid, and the supraorbital foramen. Okay. You'll have the opening of the supraorbital foramen right there. Okay, that's something very important to know. Then the medial wall, and this is highly, highly important. You'll have the lacrimal bone, you'll have the lamina patriciae, you'll have the body of the sphenoid, and there you can also have the ethmoidal foramina opening. The lateral wall, you're going to have the zygomatic bone and the greater wing of the sphenoid. And you can have the zygomatic facial foramen opening within the lateral wall. And in the floor, inferiorly, is going to be the orbital surface of the maxilla, the zygomatic bone, and the palatine bone. So it's very easy, okay, if you try to visualize it, from everything that we've learned so far. The eye sits in an orbit that is right above, it's right below your frontal bone, right? And the lesser wing of the sphenoid, all right? Medially to the lacrimal bone, all right? And to the laminate patriciae and the body of the sphenoid. Laterally, you have the zygomatic bone, you have the greater wing of the sphenoid, all right? At the floor, where this orbit sits, is going to be the orbital surface of the maxilla and the zygomatic bone and the palatine bone. Okay? Let's take a look. So this is going to be your lacrimal gland laterally. This is going to be your canthus, medial canthus right here. And this is going to be the eyelids, all right? So superior tarsus, inferior tarsus of the eyelids, all right? And this one right here is going to be your lacrimal caniculus. And this is going to be your lacrimal sac as well, all right? So, yep, it's very important that you know these structures, all right? And this muscle right here is called the inferior oblique, which we're going to talk about, inshallah, in a bit. Like, now, we have so many openings that provide passage for nerves, and these openings are within the orbit. So starting off with the superior orbital fissure. The superior orbital fissure, all right, holds cranial nerve 3, 4, 6, and the first division of the the trigeminal nerve, okay? And then the inferior orbital fissure is going to basically hold maxillary nerve, the zygomatic nerve, the optic canal is going to provide passage for the optic nerve. Supraorbital foramen is going to provide passage for the supraorbital nerve, infraorbital foramen to the infraorbital nerve, and the nasolacrimal canal to the nasolacrimal duct. These are very important, very easy, and very high yield, all right? So I think maybe the ones that are just the most difficult to learn are going to be the first two, all right? But if you think about it, the superior orbital fissure needs to provide nerves that will supply the extra ocular muscles, right? So you have the superior oblique, you have the superior rectus, medial rectus, lateral rectus. These are all supplied by 3, 4, and 6, okay? The inferior orbital fissure, because the inferior wall, if you remember the floor, what makes the floor? You have the palatine bone, you have the maxilla, and you have the zygomatic, صح? So the inferior orbital fissure is going to hold maxillary nerve and zygomatic nerve. See, it's very easy if you connect all the dots together, okay? It's going to be really easy for you to apply and you try to remember the anatomy, okay? So what sits in the orbit? See, all of this sits in the orbit, but you do not need to know this. What you need to write in that OSPE question, the eyeball, the muscles of the eye, sensory and motor nerves, and vascular supply to the eye, which is mainly the ophthalmic artery and its branches. All the branches sit within the orbit. What are the branches of the ophthalmic artery? First of all, we have the central artery of the retina. This is very important because it's the only blood supply to the retina, the inner retina. If it gets occluded, which means blocked, you'll have sudden painless vision loss. Okay? You'll have the lacrimal artery, the posterior ciliary artery, the anterior ciliary artery, the supraorbital artery, and anterior and posterior ethmoidal arteries. Okay? But then we have the extraocular muscles. The extraocular muscles are 7. Why are there 7? We included the levator palpebrae superiosus, which basically is a muscle that helps in elevating the upper eyelid. It's not part of the eye movement, but basically it just helps with elevating the upper eyelid. That's it. And it's supplied by cranial nerve 3. So you need to know that the superior rectus helps with an elevation of the eye, okay, helps with adduction and intorsion, supplied by cranial nerve 3. Inferior rectus helps with adduction as well. Medial rectus is the main muscle that provides adduction, basically moves the eye towards the nose. Lateral rectus moves the eye towards the temporal bone, and it's done by cranial nerve 6. Superior oblique helps in depressing and abducting the eye, and it's provided by cranial nerve 4, which is the trochlear nerve. Inferior oblique helps in elevating and abducting the eye, and through cranial nerve 3. Honestly, I don't see them really much asking about the functions in most of them, but see, they're pretty straightforward. Okay, you need to know the nerve supply. It's very important. So this is a mnemonic. Lateral rectus 6, superior oblique 4, the rest is 3. Okay. Very high yield, extremely high yield. طيب. There's a slide that I actually want to go to first. So this one, the nerve palsies. So if they get to tell you there's an eye that's down and out and blown, or the pupil is dilated, like this one, what nerve palsy is this? This is going to be the third cranial nerve, okay? The oculomotor. Then you'll have the eye is displaced upwards, okay? And they tell you in the scenario that the patient cannot walk down the stairs or cannot read. This is going to be the trochlear nerve. And if the eye is turned inwards and the patient cannot abduct the eye laterally, that's going to be the abducens nerve, because the lateral rectus is not working, right? And here the superior oblique is not working because the trochlear nerve is damaged. All right, so this is basically just something that you can clinically apply with whatever we just mentioned. So here, this is just a plastic model of all the muscles that we've mentioned. This is your superior oblique right here. This is the levator palpebrae superiosus, helps in elevating the upper eyelid. Here, this is your superior rectus. And this is going to be your lateral rectus. This is going to be the lacrimal gland as well. All right, very high yield. Now, this is from a posterior view. This is again your lateral rectus. This is your superior oblique. Okay. And sorry, this is your superior oblique. And this is going to be your superior rectus. All right. Okay. Now, look at this eye. Now we're more invested within the eyeball itself. Okay. Eyeball itself, we have the cornea, which is the external part. And then we have the lens, we have the ciliary bodies and the muscles that can help put the lens in place. And then we have the vitreous body, which is filled with vitreous humor. And then we have the retina. And then within the retina, we have a blind spot, which basically means that it doesn't have any causal rods and it carries the optic disc. All right, which is basically the optic nerve and retinal blood vessels. All right, and now the question is, where is the aqueous humor produced, and how does it flow, and if that flow gets blocked, how would the patient present? So the aqueous humor is produced within the ciliary body epithelium. Okay. And it flows all the way from the posterior chamber to the anterior chamber, all right? And it helps drain the trabecular meshwork right here at the iridocorneal angle. Now, I don't want you to remember this, but what I want you to remember is that the aqueous humor is produced by the ciliary body, and if there's a blockage from the posterior to the anterior chamber, all right, what's going to happen, the patient's going to have an increased intraocular pressure. And this could lead to glaucoma. Okay, very important. Now, look at the structure. What can you see? So this is the cornea. And how do I remember the structure, the different parts of it? So we have every brave student deserves excellence. So epithelium, Bowman's, the stroma, the descent, and the endothelium right here. Okay. Now, you need to know that the epithelium is stratified squamous, not keratinized. All right, and it regenerates rapidly. So if the epithelium of the cornea gets damaged, it can regenerate. However, Bowman's membrane is acellular. Okay, and it does not regenerate if it's damaged. So it's going to be permanently scarred. The stroma is the thickest. It makes up about 90% of corneal thickness, and it's transparent, and it contains the keratocyte. So if they ask you where are keratocytes found, they're found within the stroma. The descent membrane, all right, is basically the basement membrane of the endothelium. So it's the basement membrane of the endothelium right here. And basically it thickens with age, and it's very resistant to disease. And the endothelium is just a single layer of flat cells. They do not regenerate, but they help pump water out of the stroma. Okay? If you lose your endothelial cells, you will have corneal edema, right? So you will have blindness. Why corneal edema? Because it helps pump the water out of the stroma. So if it's not working, the water is going to build up within the cornea, right? And then you're going to have blindness. Okay? Now, this is the lens. Okay? So this is going to be the lens capsule. So this is going to be your outermost layer. Okay? It's an elastic basement membrane secreted by the lens epithelium. And this is the lens epithelium right here. So you can see it's a single layer of cuboidal cells. They elongate and they lose their nuclei, and then they become lens fibers. So here are the lens fibers that they become later on. Okay. As you can see, their nuclei is gone after they elongate. And basically here, within the lens fibers, you have this special protein called crystalline, which builds up within the lens fibers to maintain lens transparency. Okay, so as you can see here, this is the epithelium from the lens surface, cuboidal in shape. And then when they stretch out, they lose their nuclei. And you can see uh, it's like onion skinning, right? This is the lens fiber. And then we move on to the retina. Retina is the big guy. It has 10 different layers, and you must know every single layer and what each layer contains. Okay, so here, so this is the vitreous body of the eyeball with it. And then you will have, after the vitreous body, you'll have the optic nerve fibers, ganglion cell layer, you'll have the inner plexiform layer, inner nuclear layer, you'll have your outer plexiform, all the way to the choroid. Okay? So if you look here, طيب, this is from the choroid all the way to the vitreous. So from in, out. Okay? In, out. طيب. So all the way from the inner part, the very inner part of the retina, you'll have the retinal pigment epithelium. So basically, this helps in supporting your photoreceptors. It will absorb any stray light, all right? And then you have your photoreceptors. Photoreceptors, which is basically your rods and cones, all right? And then you'll have the outer limiting membrane. This is not a true membrane, okay? This is just a junctional complex between the Miller cells and the photoreceptor. Then you'll have the outer nuclear layer, which is where the cell bodies of your photoreceptors lie in. And then you'll have the outer plexiform layer, which basically synapses between the photoreceptors and the bipolar and horizontal cells. Then you'll have the inner nuclear layer. Then you'll have the inner plexiform layer. And then you'll have the ganglion cell layer. All right. Within the ganglion cell layer, here you'll have the cell bodies of the retinal ganglion cells and the axons from the optic nerve. And then you're going to have the nerve fiber layer. And then lastly, the one that's closest to the vitreous body is going to be the inner limiting membrane, which is the basal membrane of the Miller cells and the intersurface with the vitreous body. Now, how does the signal flow within the retina? So you'll have it from the photoreceptors, which is the second layer right here from the inside, all the way to the bipolar cells within the inner nuclear layer, okay? And then they're going to go to the ganglion cells, which is in the 8th layer, and then they will get carried all the way to the optic nerve. This is how you signal vision. Photoreceptors, the neurons and the cones, then bipolar cells, to the ganglion cells, all the way to the optic nerve. Okay, and this is a mnemonic that you can use to remember the layers. Okay, sorry. Now, what structure is shown in this image, and what will happen to the structure if you have increased intraocular pressure? So this is the optic disc, and basically, if you have increased intraocular pressure, you're gonna get what we call papilledema. All right, papilledema is a hypertensive emergency. Okay, and you need to intervene immediately, or the patient might lose vision, and the optic nerve could die permanently. Okay, now let's move to neuroradiology. So within this part, basically, we're just going to skip through really quickly. We've done the anatomy of most of the structures. Just before we start, I just want you to orient your mind when you see a CT scan, an MRI, or an X-ray. First of all, you always need to localize the lesion before diagnosing, before thinking of what the diagnosis is. Localize, see, is there any midline shifts or not? Is it medial? Is it lateral? All right. Is it in the brain? Is it outside the brain? All right. Uh, and then afterwards, after localizing the lesion, you interpret. Okay? طيب. This is just a slide just to let you know how things appear on a CT scan. So any bony structures are going to be bright white. Any acute blood is going to be hyperdense. Soft tissue is going to appear gray. Water or CSF is going to appear isodense. The fats are going to appear black, and the air is going to appear black as well. Okay. When do we use CT scans? We use it in brain hemorrhage. We use it in examining the sinuses. We use it in bone fractures. All right. Like, for example, the Lefort fractures, basilar fracture, I'd go for a CT scan. An MRI is when I want to examine the soft tissue. All right. When I want to look at the brain parenchyma more further. Okay. That's what I'll use it. That's when I'll use an MRI. An X-ray, again, is for like sinus opacification, for example, any skull fractures, any foreign bodies within, for example, the nasopharynx. I'll definitely go for an X-ray. Okay. Even when I will look at the airway, I'm gonna go for an X-ray. Okay. So you need to know you need to know that within a radiology image, okay, sutures happen to appear with a zigzag line fashion. Okay, fractures are sharp, طيب, and they're straight, تمام, and usually they will cross over the suture. Okay, and the vascular markings, usually they're going to be branching. Okay, so if you can see here, طيب, if you can look, this is a branching marking low-key. Okay, this one is definitely vascular marking. Okay, like it's right here. طيب. So it's not a fracture. A fracture is just going to be a straight line. Okay, and then right here, you're going to see this zigzag kind of lining. All right, this is going to be a suture. Okay, same goes here. You're going to have this zigzag kind of lining. This is your lambdoid suture. It's going to be your coronal suture right here. Okay, and yeah, it's very important that you not mistaken a suture for fracture and vascular marking. So a fracture is a straight line, does not branch. All right, vascular markings, they do branch. All right, sutures are usually zigzag, bilateral, and you would know the locations if you know the anatomy. طيب. An osteolytic lesion is basically when the bone eats itself up, right? Osteolysis. So this is in a patient who has multiple myeloma, and this is basically how an osteolytic lesion will appear. Okay, a skull fracture right here. You can see it's very first of all, we localize it. Okay, so it's somewhere like around the temporal area, and it's a fracture. You can see it's like a straight cut. Okay, like right here, I've just added this slide just so that you can understand something really important. What do we mean by when we say extraaxial and intraaxial? When I say extraaxial, I mean to say that it's outside the brain. So when I have extraaxial hemorrhage, I have bleeding outside the brain. Okay. Epidural hematoma, subdural hematoma, subarachnoid hemorrhage, they're all outside the brain. When I have intraaxial, it means that it's within the parenchyma of the brain. Okay. And it's usually seen in, like diffuse axonal injury, for example. That's something that you'll see. However, I don't think this is really important for you to know. I just put it here for the sake of completion. However, what you need to know is that when you see bleeding within the brain, it's called intraaxial. Okay. And of course, you need to know the meninges, the dura mater, arachnoid mater, pia mater. Okay. Subdural space is the space between the dura and the arachnoid, and subarachnoid is between the arachnoid and the pia. Okay, and that's where your CSF runs. All right. So let's take a look at this beautiful hematoma right here. It looks like a lemon, right? This one is an epidural hematoma, okay? An epidural hematoma, which happens between the skull and the dura, all right? And this is due to the middle meningeal artery. By now, you should know it. I've repeated it like 3 times throughout the video. And usually it happens from temporal bone fractures, especially in children, okay? And it does cross the midline, so you need to know that, but it does not cross any sutures, okay? Subdural is between the dura and the arachnoid, and this is due to bridging veins. So we have these veins that we call bridging veins. When is this common? This crescent-shaped bleeding, when is it common? When do I usually see it? I see it in elderly patients, patients who are really, really old, like 70 plus. We see it in alcoholics, right? Why? Because their brain shrinks. And imagine this brain is shrinking, shrinking, shrinking. What will happen to the bridging vein? They're going to disrupt. Okay. So that's something about the subdural hematoma. Now, let's have a quick case. So this is all right. This is a 52-year-old woman with a history of hypertension and smoking, presenting to the emergency department with sudden onset, severe headache she describes as the worst headache of my life. She states it began abruptly while she was training at the gym, reaching maximal intensity within seconds. She had had previous episodes of vomiting and was found by staff sitting on the gym floor, confused and holding her head. All right, she has high blood pressure. Everything else is normal. She had mild photophobia and neck stiffness on flexion, no focal neurological deficits. Pupils are equal and reactive, no papilledema. What do you think is wrong with this patient? Look at the scan. So if you look at the scan, you see like a star, right? I don't know if you can pick it up. This is subarachnoid hemorrhage, all right? Usually it happens from a ruptured aneurysm. So sometimes we have weak areas in, within the, for example, the circle of Willi, all right? Very commonly seen in the anterior communicating artery, okay? And sometimes we can have these aneurysms, and sometimes they rupture suddenly out of nowhere, okay? When they rupture, you will see this basically blood within the CSF, okay? So this is basically subarachnoid hemorrhage, okay? It's very important that you know it. It also could be caused during trauma, or you can have something we call arteriovenous malformations, okay? However, if you see the star-shaped kind of scan, it's subarachnoid hemorrhage, okay? Now, something else that I want you to pick up, which is also very important, the timing of subdural hematoma or hemorrhage, okay, can be deciphered from a scan. How? If it was acute, it's going to be hyperdense. Look, it's hyperdense, right, compared to the soft tissue here. However, after a month, it's going to become isodense, right? And then 2 months later, when it becomes chronic, okay, it's going to become hypodense. So if it's acute, it's going to be hyperdense. If it's subacute, it's going to be isodense. And if it's going to be chronic, it's going to be hypodense. Okay. Like, so this is the eye. Regarding the eye, probably you would want to identify the muscles, all right, in a radiology scan. So these are your extraauricular muscles. This is medial, this is lateral. So here you're going to have your superior rectus, lateral rectus, medial rectus. طيب. This long muscle is going to be your superior oblique. And this one that's just right below the eyeball is going to be your inferior rectus. So if you know the anatomy very well, you can apply it here perfectly. Okay. Now, the medial wall of the eye or the orbit is very high yield in the radiology lectures. Okay, so do expect a question from it. So look, this is the eye, right? This is the medial wall right here. Okay, and then you'll have the lateral wall right here. This is the optical foramen right here. All right, and then here you'll have the orbital floor, and this is the orbital roof. All right, so if we refresh, what makes my orbital roof? Frontal bone, lesser wing of the sphenoid. What makes the floor? Maxillary, the maxilla, the zygomatic, right? The heart palate as well. Okay, and what makes my medial wall? So it's gonna be the maxilla, the lacrimal bone, ethmoid, which is the lamina papriciae, and the body of the sphenoid, MLES. Okay, very, very high yield. Okay, so you expect a question, they can ask you about it. Okay, now, how do they divide the eye? Okay, they divide the eye into intracaudal and extracaudal. So this is an intracaudal space, okay, which basically means that it's within the muscle cone. And this one is extracaudal, which is basically out of the muscle cone, okay? And this is your globe right here. طيب. So what's within the intracaudal? The intracaudal, here you'll find your oculomotor nerve, your optic nerve, your nasociliary nerve, abducent nerve, ophthalmic artery, okay? Basically, all the contents of the orbit. صح? If you go back and review the contents of the orbit, most of them are going to be here. طيب. Extracaudal, you're going to have your lacrimal gland, you're going to have the lacrimal nerve, frontal nerve, and trochlear nerve, okay? All right. So it's very important that you know the contents of intra and extracaudal spaces. Now, which view can I use to best see the medial and the lateral rectus? That's going to be the axial. Okay. Which view can show me all four rectus muscles? That's going to be the coronal. And then which view is going to show me the superior and the inferior rectus? That's going to be the sagittal. Okay. Now, if you look here, all right, now we're back to the pterygopalatine fossa. Okay. I love the pterygopalatine fossa. I really feel it's a very high yield concept, and I think you guys are going to be questioned about it. So look at it. This is your pterygopalatine fossa. Okay. This is your sphenopalatine foramen. All right, this is the pterygoid canal. All right, this is the pterygomaxillary fissure. Okay. Now, remember, it's a connection hub, right? BPF is a connection hub, and it connects me to so many parts within the brain, and you need to know the openings, all right? So there are so many openings that it can connect to. So anteriorly, you have the maxillary sinus. Posteriorly, you can have the metacranial fossa through the foramen rotundum, where the maxillary nerve passes through. You'll have laterally the pterygopalatine. You'll have the pterygomaxillary fissure, which connects us to the infratemporal fossa. All right, superiorly, it can connect you all the way to the orbit, and you need to know these very well. And something that I found within the slides, a disease called juvenile nasopharyngeal angiofibroma, which is seen in adolescents. It originates within the sphenopalatine foramen. Okay. All right. Can you name this bone for me? So this is part of the nasal septum. What's this bone? This is the vomer. Comes from the skull. And this is the perpendicular plate of the ethmoid, and this is the septal cartilage. All right? And this is your pterygopalatine fossa. Okay. This is the sphenoid right here as well. This is the perpendicular plate of the palatine bone right here. Remember the connection hub slide? I'm just translating that slide into radiology right here. So I know it's a bit overwhelming, but I'm going to break it down. So here, this is your pterygopalatine fossa, right? It's going to communicate with the infratemporal fossa via the pterygopalatine fissure. And it's going to communicate with the nasal cavity via the sphenopalatine foramen. And it can communicate with the middle cranial fossa via foramen rotundum. All right. Now, this is the Vidian canal right here, Vidian canal, or the pterygoid canal running to the foramen lacerum. And then here, you'll have the pterygopalatine fossa in communication with the infraorbital fissure. All right. And here you have the sphenopalatine foramen that will communicate with the orbit via the infraorbital fissure, and here to the ITF via the pterygomaxillary fissure. Okay. Again, it will communicate with the orbit how? To the infraorbital fissure. Okay, so it's very important that you take that slide of the content and how the connection hub and how it connects with all that, because they can ask how a disease could spread. For example, from the pterygopalatine fossa to the middle cranial fossa, and then you'll say foramen rotundum. All right. And if they ask, for example, how a disease from the nasal cavity is going to reach the pterygopalatine fossa, then you're going to say through the sphenopalatine foramen. Okay. Okay. So this is a question right here. A 56-year-old man presents to the emergency department with infothalamus. All right. Infothalamus. So the eye is like sunken in a bit. All right, sunken left eye, diplopia on upward gaze, numbness of his left cheek. He was assaulted a day ago and punched in the face. So he was punched in the face. An examination, there's periorbital ecchymosis on the left. There's upward gaze restricted in the left eye. His vision is intact. There's reduced sensation and distribution of the infraorbital nerve, and a CT of the face is performed. What is the diagnosis, and which wall of the orbit is most commonly affected, and what structure does it overlie? So, first of all, what's the diagnosis? What do you think this is? So this is traumatic, صح? It's a traumatic finding. So what do you think it is? This is a left orbital blowout fracture, and it's most commonly seen in the orbital wall, which is the inferior wall, which forms the roof of the maxillary sinus. Okay, now how did this injury lead to this fracture? Like the mechanism of the injury lead to this fracture? Okay, and what orbital contents are most likely to herniate through the fracture? So in here, if you see, okay, there's a direct blow. It decreases the intraorbital pressure suddenly, and then the weakest wall is going to get affected, okay, which is the orbital floor. And then the orbital fat and the inferior rectus muscle are going to herniate through the defect, which is right here. Okay, so the inferior rectus muscle is going to herniate into the maxillary sinus right here. Okay, it's very important that you know that. Herniation of this inferior rectus is going to cause the restriction of the upward gaze and the diplopia that you see in the patient. Now, why does he not have numbness of the cheek? This is due to basically the fracture of the orbital floor. It will injure, the nerves of the maxillary nerves, right? Which is going to cause numbness, all right? On CT scan, what two abnormal findings would you expect to see? Again, the fracture in the left orbital floor and the herniation of the contents into the maxillary sinus. Okay, it's very important that you know that. And by the way, when you see a pathology on a scan, always try to compare it with the normal part. So this is normal, right? Try to compare and see. Like here, for example, this is the maxillary sinus is intact. Here, you can't see the air anymore. Here you see the orbital floor intact. Here you don't see it anymore. See, it's like it's fractured. Okay, right. So this is basically just a summary of what I said, okay, that you can refer to. All right. Now, this is a second case. This is a 19-year-old male university student presenting with a 10-day history of frontal headache, fever, and nasal congestion. He was prescribed amoxicillin by his GP 1 week ago, but has not improved. Today, he develops a generalized tonic-clonic seizure. On arrival, he's febrile, confused, and has mild neck stiffness. He has tenderness over his left maxillary and frontal region. He has high neutrophils, and basically a CT has been done. So the first question is, what has developed intracranially and what is the characteristic CT appearance that distinguish it from a simple area of cerebritis? So I want you to look carefully and think. Now, this is a brain abscess, okay? And why do I say it's a brain abscess and not just cerebritis? Because there's a rim enhancing lesion, all right? A ring enhancing lesion, all right, with a well-defined hypodense center. Okay. All right. Like, what else? What else would we see? We will see also vasogenic edema around the lesion. All right. So I'll see vasogenic edema right here. So they'll ask me, can you trace the anatomical route by which the infection spread from the sinuses to the intracranial compartment in this case? Of course, it could either be frontal or maxillary sinusitis, all right? Direct spread to the posterior sinus wall, all right? And then, to the cavernous plexus, all right? Intracranial compartment all the way to the cerebral parenchyma, okay? Or it could come from the cribriform plate, erosion of the cribriform plate, all the way to the subfrontal area. In this case, you'll have spread again via the cavernous sinus to the middle cranial fossa, as you can see right here. Okay. Now, why did this patient develop a seizure? This patient developed a seizure because the abscess happened in the temporal region, all right? And usually when it happens within the temporal region, okay, that's where you develop seizures, okay? Now, list 3 image findings you would expect on the CT scan and which modality, CT or MRI, is superior for evaluating the extent of the intracranial spread and why. So the 3 findings, again, it's a ringed lesion with a hypodense center, vasogenic edema, and sometimes there could be a midline shift. Now, remember the first slide I told you. If I want to examine the brain parenchyma, that's going to be MRI. Okay, MRI is always superior to that, because it could show me the meningeal enhancement and if there's any cerebritis to rule out. Okay, so this is brain abscess. It was covered in the slides. That's why I thought I should bring it up here. Now, paranasal sinuses, development and functions. So again, the 2 sinuses present at birth are going to be maxillary and ethmoid. Frontal and sphenoid are not present. The frontal usually takes 1 to 12 years. Sphenoid starts to be there within 2 years. Okay. Now, this is the osteomeatal complex. The osteomeatal complex is made up of the semilunar hiatus, the maxillary ostium sinus, infundibulum, ethmoid bulla, all right? The idea is that the osteomeatal complex is the final drainage of the frontal, maxillary, and anterior ethmoid sinus. This is basically the most important takeaway from the slide. It's present at birth, and any obstruction to it, would lead to impaired sinus drainage. Okay, so you would need to go in and drain the sinuses so that you would not cause abscesses and infections. Okay, so this is the most important part, what it drains: frontal, maxillary, and anterior ethmoid sinuses. Now, honestly, I've never seen these before in any OSPE questions, but it's also nice to know them. If you want to see the maxillary sinuses, the best thing is you do a water view. And if you want to see frontal sinuses, the best you do a Caldwell view. and sphenoid sinuses, lateral view, and to be able to see the zygomatic arches, maxillary sinus walls, you do a submental vertex. Honestly, I'm not bothered by these, and I don't think you should too. However, these might pop up as an MCQ, but they're really low yield. I don't think they're going to be asked. I just put it here for the sake of completion. Okay. So what sinus is this? And where does it drain into? And what's the blood supply? So this is the frontal sinus, drains into the middle meatus, remember? To the middle meatus, and it's supplied by the supratrochlear, supraorbital, and anterior ethmoidal arteries. Okay. Now, what's this sinus? Where does it drain into? And is it present at birth? It's the maxillary sinus, again, middle meatus, and yes, it's present at birth. Now, what's the blue and the green sinuses? So the blue one is ethmoidal, right? You should say that. So what's the blue one and what's the green one? And where do they drain into? And are they present at birth? Okay, so ethmoidal sinuses drain into the sphenoethmoidal recess. Only ethmoid and maxillary are present at birth. Okay, so the sphenoid sinus borders, you have to know this. So this is the sphenoid sinus, right? Okay, superior to it, you'll have the sella turcica, where the pituitary gland sits. And right next to the pituitary gland, you have the cavernous sinus. صح? Inferior to the sphenoid sinus, you'll have the nasal cavity. Anterior to it, you'll also have nasal cavities and the posterior ethmoidal cells. And laterally, you'll have the cavernous sinus and the cranial cavity. طيب. I don't think you're going to be asked these, but you need to be able to pick it up on a lateral view of a radiology scan. Okay, so it's right here. How would you know? I'd also just look at the sella turcica right here. Okay, and I just pick it up. It's the closest thing to the cranial cavity. Okay, so this is going to be your maxillary sinus. It's the largest sinus, right? So it's going to be your maxillary sinus. This is going to be your hard palate, and this is going to be your oropharynx. Okay, this again, maxillary sinus. This is your nasopharynx. Okay, and this is the turbinate. Now, why is this not the oropharynx? Because this is the hard palate, right? This is the hard palate. خلاص, I've moved down the nasal area, so I'm at the oropharynx. However, here, I still can see the nasal structures, so this is going to be the nasopharynx. Okay, this is the globe. This is the eye right here. Then here you have the nasal septum. Okay, if you can actually see, it's a bit deviated to the left. All right, here, this is your ethmoidal sinus. This is your sphenoid sinus, and this is your clivus right here. Okay. Then this is the turbinate. This is maxillary. You can see here it's opacified. This patient can have sinusitis actually. Okay. Then you have the lateral lamina of the thyroid process. Here you have the nasopharynx. This is your C1. And this is the pterygomaxillary fissure that takes the pterygopalatine fossa to infratemporal fossa. Okay. All right. So this is your sphenoid sinus. This is the middle turbinate. This is the inferior turbinate. Okay. This is your zygomatic arch. Okay. This is the mandible. Okay. This is your frontal lobe. All right. This is the superior oblique muscle right here. And then you will have the optic nerve right in the middle. I don't know if you can see that there's a bit of hyperdensity here. This is going to be your optic nerve. Then you have lateral rectus, medial rectus, inferior rectus. And then you'll have the zygomatic arch. And then you have your hard palate. And this is going to be your middle and inferior turbinates. Here, this is going to be your frontal sinus because it's, within the cranium, right? So frontal sinus, nasal bone, and this is going to be the nasal cavity, and this is going to be the teeth. Okay. And again, it's another picture. So this is the nasal bone. I think this could be part of the perpendicular plate of the ethmoid, right? This is going to be the vomer, frontal sinus, all right? Could be ethmoidal sinuses, all right? And then here you'll have the tongue, okay? So yeah. Now, this is your frontal sinus again. This is your sphenoid sinus. And this is your hypophyseal fossa, or like sella turcica. This is your clavus, and this is your this is your nasopharynx actually. Sorry, this is supposed to be 7. Okay. I think this is the C1 structure. What structure does the star represent? So the star actually represents the mastoid air cells. Okay. So if you can appreciate that this is the ear right here, and this is the mastoid air cells. Okay. This is just another diagram showing the middle turbinate, inferior turbinate, all right, and the nasal septum right here, okay, and the maxillary sinuses, all right, and this is the heart palate right here, just so that you can just appreciate the paranasal sinuses at the nasal cavity. Okay, now look here. Within the nasal structure, we have the opening of the eustachian tube that connects it to the middle ear. And then we have something called torus tubarius. And then we have the fossa of Rosenmuller. Okay. Fossa of Rosenmuller basically is a posterior superior lateral recess of the nasal cavity. And this is the most common side of nasopharyngeal carcinoma. Then you have the torus tubarius. Okay, here you have mucosal elevation anterolateral. All right, so it's in front of the fossa of Rosenmuller, and this is caused by the medial opening of the eustachian tube. If this get enlarged, it will block the eustachian tube, and you can have something called conductive hearing loss. All right, and then we have something else called the adenoids. Adenoids basically are lymphoid tissue that make up the posterior superior wall. Okay. If you can see, these are the adenoids right here. Now, if the adenoids actually get enlarged, okay, it's going to compress and basically decrease the space within the nasopharynx. You're gonna have snoring, apnea, recurrent infections, and usually this is seen in patients who have lymphoma. Okay, this is just different scans, just that you can appreciate the nasal cavity, and you can also appreciate the larynx and the hyoid bone at different levels. So here you can see the mandibular condyle, the nasopharynx, and then we go. Then this is the hyoid bone. All right, this is your jugular veins on the side. Okay, and then you move just below the hyoid. You'll find that your thyroid cartilage, your vocal cords, and this big chunk of muscle is called the sternocleidomastoid. Okay, so this is your hyoid bone. Okay, now areas could be supraglottic, glottic, or subglottic, depending on where the vocal cords are. So at the hyoid bone level, this is the supraglottic area. Here you can find the jugular veins. If you actually go back, here you can find the jugular vein, the vallecula, the piriform sinus, common carotid arteries. Okay, so basically it. The thyroid cartilage, so at the level of the thyroid, right here, you can find the true vocal cords, sternocleidomastoid. Okay, and the cricoid cartilage, which is the subglottic area. All right, here you'll find the tracheoesophageal groove, cricoid ring, and the oval-shaped airway lumen. Okay, oval-shaped airway lumen. All right, the thyroid cartilage. You can also see the sternocleidomastoid muscle. Okay, like the zygomaticomaxillary complex fractures. So when you have a fracture, okay, that involves the maxilla, the zygomatic arch, okay, it's called the zygomaticomaxillary complex fracture. Okay, has to involve 3 components. So if you look carefully, you will have a fracture to your zygomatic arch. you will have a fracture to the inferior orbital rim and the posterior sinus wall. So right here, okay? And you'll also have a lateral orbital rim, fracture, okay? Mechanism, basically, they will tell you in the question that there was a direct blow or trauma to the cheek, okay? And basically here you would have to do a CT so that you can assess the bony landmarks of the orbit and see if there are any fractures or not, okay? Uh, so these last couple slides are just like clinical radiology. So first we have croup. Croup happens from parainfluenza, okay? And usually we see what we call the steeple side. So if you look here, this is a steeple side, and it also looks like a wide bottle side or like an inverted V side, okay? So this is something that you'll see on an AP radiograph. Usually, this is found within the subglottic area. So you'll have subglottic edema, you'll have hypopharyngeal deviation, distension as well. All right, so these are very important for you to pick up. So if we're having subglottic edema, what will happen to the airway resistance? It's going to increase. That's why these patients are going to present with inspiratory stridor. Okay, so that's very important to know. You don't really need to know the management, but I just put it here just for the sake of completion. Corticosteroids, we give nebulized adrenaline and supportive care. Okay. Now, what is this? Can you pick up what's that? Right here. Looks like a thumb, right? Looks like a thumb. This is epiglottitis, which is in the supraglottis area. All right, it's very common in children who have H influenza infection. All right, if it's more in adults, then it's going to be streptococcus. Okay, thumb sign, very, very high yield. Okay, and that's pretty much it for the epiglottitis. Then Graves' disease. So I don't think that you guys are actually going to be questioned about this. However, the takeaway from this slide is that you need to know that your thyroid is going to be enlarged, right? And with that, you'll have something we call Graves' ophthalmopathy, okay? Where the extra ocular muscles are going to get enlarged, okay? And because they get enlarged, because of this hyperactivity in the body, they get enlarged, right? They're gonna present with exophthalmos, where the eye is basically protruding. So it's called proptosis. Okay. And with time, because of that proptosis, and this extraocular muscle enlargement, the patient can have optic nerve compression and can have visual loss. Now, something very important. Let's say we treated the Graves' disease and the patient thyroid levels are back to normal, everything is normal and all that. Will Graves' ophthalmopathy go away? No, because these muscles are going to be enlarged permanently. Okay, basically that's really the takeaway from this slide. Juvenile nasopharyngeal angiofibroma. This is a benign nasopharyngeal tumor. Okay, within the nasopharynx, happens only in adolescent males. It's a very highly vascular tumor, so you do not do a biopsy in it. Okay, because it can lead to bleeding. How will the patient present? He's going to have multiple recurrent epistaxis, nasal obstruction, and a nasal mass. Okay, and if you remember, I mentioned that it originates within the sphenopalatine foramen. Okay. Now, if you look here, this is how a juvenile nasopharyngeal angiofibroma is going to look like. Okay, literally, you have the sphenopalatine foramen somewhere here, originating from there, and it penetrates all the way into the nasopharyngeal cavity. Okay, foreign bodies. Again, for foreign bodies, you'll do an X-ray. Okay, and basically, this slide is just to show you how they will look like on an X-ray, and where would they be commonly lodged. Okay, so in the tonsils, needles are going to be lodged in there at the base of the tongue. probably needles, fish bone as well, piriform fossa, bones, needles, and dentures. But within the esophagus, which is the most common, you'll have coins, uh, food, safety pins, all right? However, the takeaway is that they're gonna look like this, and you do an X-ray, okay? Lastly, we have here the orbital cellulitis. So here you can appreciate, okay, the hyperdensity in this area, okay? Usually, orbital cellulitis is due to ethmoidal sinusitis, okay? Most common. طيب. Uh, and you can here, like see that there's proptosis as well, because they're not like lining similarly. And then from orbital cellulitis, you can also develop orbital abscess. Okay, orbital abscess, if you can see, it is within the intraconal collection. So it's going to be a true intraconal collection, rim enhancing on CT and MRI. And because it's within the intraconal, the optic nerve is there, so you can have visual loss. All right. So how does it spread? We have from the ethmoidal sinusitis to the lamina propria to the orbit, optic nerve, cribriform plate, and it could go intracranially. If it goes intracranially, you can have brain abscess, as I mentioned. Remember the clinical scenario? Brain abscess, rim enhancing mass with vasogenic edema, all right, and this thick, shaggy wall of the mass, all right, and it can cause seizures because it's in the temporal lobe. Then we have something called the subperiosteal abscess. The subperiosteal abscess is basically a crescentic, all right, a crescentic hypodense collection along the medial wall of the orbit, on the medial wall, okay? So it's also right here, if you can appreciate it, okay? It's a crescentic hypodense collection along the medial wall of the orbit between the lamina propria and the periorbital. And with that, I conclude my session. Thank you so much. I apologize for my voice. I was pretty sick, and I wish you all the best for your exam. And you're one exam away from being third years. And wish you all the best. If you have any questions, please feel free to reach out to me at any time. And please scan the barcode and leave me a nice review. Thank you so much, and have a good day.